check. Hello, hello, hello.
The eyes may be small in size, but they hold the power to reflect life's greatest emotions. When vision cannot be restored, compassion and science come together to restore something equally precious: confidence and dignity and hope. On that inspiring note, a very good morning to our respected dignitaries, esteemed resource person, distinguished faculty member, delegates, participants, and dear students. I am Vijayaruth from the Department of Optometry, School of Allied Health Sciences, Vinayaka Missions Research Foundation, deemed to be University, Puducherry.
I am Dinesh from Department of Optometry, School of Allied Health Science, Vinayaka Missions Research Foundation, deemed to be University, Chennai.
And I am Dia from Department of Optometry, School of Allied Health Sciences, Vinayaka Missions Research Foundation, deemed to be University, Salem. Together, we are honored to convene this prestigious academic gathering. To give us immense pleasure to welcome you all to V-Opto 2026 hands-on workshop on ocular prosthesis organized by Department of Optometry, School of Allied Health Sciences, Vinayaka Missions Research Foundation, deemed to be University. Today's theme, Revive and Rehabilitate, beautifully reflects the essence of ocular prosthetic rehabilitation, where science, artistry, and compassion come together to restore not only appearance but also confidence, dignity, and quality of life. We are truly delighted to have each one of you with us and hope today's workshop inspires meaningful learning, collaboration, and innovation in the specialized field of eye care.
தமிழ்த்தாய் வாழ்த்து ஒலிக்க, தமிழ் உறவுகள் இனிதாக இருக்க, தமிழ்த்தாய் வாழ்த்து முழங்க, நமது தமிழர் சிங்காரமே உலவட்டும். இத்தகைய இனிமை மிகுந்த தமிழ் மொழியை போற்றும் வகையில் இந்த இனிய நாளை தமிழ்த்தாய் வாழ்த்துடன் துவங்குவோம். அனைவரும் தமிழ்த்தாய் வாழ்த்துக்காக எழுந்து நிற்குமாறு பணிவுடன் கேட்டுக்கொள்கிறோம். Thank you all. Kindly be seated. The lighting of a traditional lamp symbolizes the dispelling of darkness through the light of knowledge, wisdom, hope, and enlightenment. It signifies the beginning of successful and meaningful journey. To invoke the blessing of Almighty and to make an auspicious beginning of V-Opto 2026, we now invite our distinguished for ceremonial light lamping. May we respectfully invite Professor Dr. B. Sendil Kumar Sir, Dean, School of Allied Health Sciences, Vinayaka Mission Research Foundation, Salem, Professor Tamil Chodar R, Administrative in Charge, Head of the Department of Optometry, School of Allied Health Sciences, Vinayaka Mission Research Foundation, Salem. Our esteemed resource person, Ms. Priya Balasubramaniam and Mr. Satish Kumar, along with Mrs. Venila, Head of the Department of Optometry, School of Allied Health Sciences, Vinayaka Mission Research Foundation, Puducherry, and Mrs. Banu, Head of the Department of Optometry, School of Allied Health Sciences, Vinayaka Mission Research Foundation, Chennai, to kindly come forward and light the ceremonial lamp.
Thank you, respected dignitaries. May this divine light symbolize wisdom, innovation, compassion, and excellence, guiding us throughout today's workshop. A warm welcome has the power to create lasting impression and meaningful connection. It's now my privilege to invite Professor Tamil Chudar R., Head of the Department of Optometry and Administrative in Charge, School of Allied Health Sciences, Vinayaka Missions Research Foundation, Salem. Ma'am is an accomplished optometrist, academician, and administrator with over 2 decades of rich clinical, academic, and administrative experience. An alumna of the prestigious Allied School of Optometry, BITS Pilani, she holds master's degree in optometry, public health, and psychology, and is also a certified good clinical practice professional and an ISO lead auditor. Her exemplary contribution to optometry education and research are reflected through 15 research publications, 7 patents, funded research projects worth over rupees 16 lakhs, 1 authored book, 5 book chapters, and the successful guidance of more than 100 undergraduate and postgraduate research projects. She has also been invited as a resource person, numerous conferences, inspiring students and professionals across the country. She has also played a pivotal role in community eye care, leading extensive outreach programs that have screened over 25,000 individuals and facilitated the distribution of nearly 12,000 spectacles over the past 5 years, and recipient of the Best Head of the Department Award for the 3 consecutive years, Best Employee of Faculty of Allied Health Sciences 2025 to 2026, and the Women Leadership Award 2025 to 2026. Ma'am continues to inspire through her unwavering commitment to academic excellence, research, innovation, and student mentorship. We are truly honored to hear leaders in extending a heartfelt welcome to this esteemed gathering. Ma'am, we respectfully invite you to deliver the welcome address.
Thank you, dear, for that introduction. A very good morning to one and all. It gives me immense pleasure to welcome you all to V-Opto 2026, this hands-on workshop on ocular prosthesis. On behalf of School of Allied Health Sciences, I extend a very warm and heartfelt welcome to each one of you. Dean of SAHS, Professor Dr. B. Sendal Kumar sir, he has been the man of inspiration to all of us, both faculties and students. His visionary thoughts, perseverance, and people management through his personal touch has made him the most adorable leader that he is today. We all feel blessed to be working along with him, and we will always be grateful for the liberty he gives us to explore new ventures and grow as a professional. Sir, it's such a pride to have you with us today, and a heartfelt welcome to you, sir, on behalf of the organizing committee of the V-Opto and the Students' Fraternity of Optometry. A warm welcome to our distinguished speakers, Mr. Satish Kumar, Senior Lecturer, Government College of Optometry, RIOGOH, Chennai, EGMO, Mrs. Priya Balasubramaniam, Ocularist and Optometrist, Founder, Iris Perfect, Maxillofacial and Ocular Prosthesis Clinic, Chennai. We warmly welcome you both, and thank you for being here today with us. I extend a welcome to Mr. Mithuraj, Director in Charge of School of Allied Health Sciences, Chennai campus. Welcome, sir. Professor Mrs. Vanilla, Head of the Department Optometry, SAHS Puducherry campus, with an experience of around 20 years in academics, is a favorite teacher for all, the one that molds the students for life, and that too always with a smile. One of the oldest employees of the organization, she's always stood for the upliftment of optometry and has proven to be an asset to us. Welcome, ma'am. A hearty welcome to Ms. Banu, Assistant Professor, HOD Optometry, SAHS Chennai campus, who is highly dedicated and academically driven and an optometry professional with a strong experience in teaching, clinical practice, academic coordination, and quality assurance activities. She is highly passionate about creating an engaging learning environment, integrating innovative teaching methodologies, and contributing towards academic excellence and healthcare education. A very warm welcome to you, ma'am. I extend a pleasant welcome to all the faculty members of SAHS, friends and faculties from other colleges, and my beloved budding optometry students. This workshop on ocular prosthesis with the theme Revive and Rehabilitate, it represents an important step in advancing your clinical knowledge and practical skills in the specialized field of ocular prosthetics. An accurately fabricated ocular prosthesis not only restores facial aesthetics but also changes the way of life to an individual. The objective of today's workshop is to bridge the gap between theory and clinical practice by providing you, the participants, with the hands-on experience to the principles, techniques, and materials involved in the fabrication and fitting of ocular prosthetics. Learning directly from the experienced experts will enhance your technical competence and will encourage a patient-centered approach to rehabilitation. I take this opportunity to express my sincere gratitude to our distinguished resource persons who have graciously agreed to share their expertise and valuable clinical experience with us. Your willingness to mentor and guide our participants is deeply appreciated. And to all the participants, I encourage you to make the most of this learning opportunity. Be inquisitive, actively participate in every session, ask questions, and engage wholeheartedly in the practical demonstrations. The skills and insights you gain today will undoubtedly strengthen your professional practice and enable you to provide compassionate and comprehensive care to your future patients. I am confident that this workshop will be enriching and a rewarding experience for everyone present. Let us work together to promote excellence in patient care through innovation, collaboration, and continuous learning. With these words, I once again welcome you all, and I hope you have a productive, interactive, and memorable learning experience. Thank you.
Thank you very much, ma'am, for your gracious words of welcome and for setting a positive tone for today's conference. Every successful conference is inspired by visionary leadership and words of wisdom. It is now our distinct honor to invite our respected Dean, Professor Dr. B. Sendil Kumar, Dean and Director, School of Allied Health Sciences, Vinayaka Missions Research Foundation, deemed to be University. Sir is a distinguished academician, administrator, researcher, and healthcare leader with over 25 years of rich experience in academics, healthcare administration, research, and quality management. As the founder dean of the School of Allied Health Sciences, he leads nearly 20 undergraduate and 11 postgraduate programs across Salem, Puducherry, and Caracal campuses. He also serves as the head of transformation at Vinayaka Missions Hospital, Salem, and holds several prestigious professional positions including CIA Salem Healthcare Panel Chairperson, member of CIA Southern Region Subcommittee on Education, Skills and Job Creation, and District Sustainability Mentor under the Mahatma Gandhi National Council of Rural Education, Government of India. A highly accomplished scholar, Sir holds an impressive range of academic qualifications, including a Bachelor of Dental Surgery, Master of Business Administration, Master of Public Health, Master of Philosophy, Doctor of Letters, and Doctor of Sciences, along with several distinguished fellowships. He is also a qualified NBA assessor, certified Six Sigma Black Belt, and ISO lead auditor for multiple international quality and educational management standards, reflecting his unwavering commitment to excellence in healthcare and higher education. His remarkable academic contribution include more than 40 research publications, 19 national and international patents, 2 authored books, 4 book chapters, and over 125 prestigious national and international awards. A widely respected speaker and mentor, Sir has delivered invited lectures and served as a panelist at around 80 national and international academic forums. We are truly privileged to have such an inspiring leader with us today. Sir, we respectfully invite you to share your keynote address with this esteemed gathering.
Distinguished resource person, Mr. Satish Kumar, Senior Lecturer, Government College of Optometry, Chennai Egmore, and Mrs. Priya Balasubramanian, Ocularist and Optometrist, founder Iris Perfect, Maculofacial Ocular Prosthesis Clinic, Chennai, and faculty members from various institutions, and my dear beloved faculties, healthcare professionals, and my dear students. Wishing all a very good morning. Good morning. Thank you. It is both an honor and privilege to address this gathering at the inauguration of this hands-on workshop on ocular prosthesis. Healthcare today is rapidly evolving, driven by technological innovation, interdisciplinary collaboration, and an unwavering focus on improving the quality of life of our patients. While medicine strives to save lives, rehabilitation restores the dignity, confidence, and independence that illness or trauma may take away. Ocular prosthetic rehabilitation stands as a remarkable example of this philosophy, and that's why this workshop today. The loss of an eye is far more than a physical disability. It affects an individual's self-image, emotional well-being, social interactions, and overall quality of life. The role of an ocular prosthesis extends beyond replacing a missing eye. It restores hope, confidence, and the courage to engage with the world once again. Every prosthesis fabricated with precision, compassion, and scientific excellence becomes a symbol of renewal confidence for the individual who wears. This workshop reflects our institution's commitment to competency-based education and experiential learning. Knowledge acquired in classroom finds its true value when translated into clinical practice. Hands-on training enables participants to develop technical precision, clinical judgment, problem-solving abilities, and the confidence required to manage real-world patient needs effectively. I strongly believe that as an educator, our responsibility extends beyond imparting technical skills and nurture professionals who combine scientific knowledge with empathy, ethical practice, effective communication, and a deeply respect for human dignity. To our participants, I encourage you to approach this workshop with curiosity and enthusiasm. Observe carefully, ask thoughtful questions, engage actively in every practical session, and learn not only the techniques but also the philosophy of patient-centered rehabilitation. The skills you acquire today may profoundly influence the life of many patients in the years ahead. I express sincere appreciation to our distinguished resource person for generously sharing their expertise and clinical experience. I take this opportunity to applaud the Optometry team of SAHS for the tremendous efforts they put in and for being wholesomely student-centric, be it in the innovative teaching methods, using VR, experiential learning in the form of iPark in Salem, offering industry-specific and industry-design courses with Z's, Bosch and Lab, and celebrating 12 events in 12 months of the year, organizing eye screening program for the public, and offering free spectacles, and proud to add that they have distributed around 15,000 free spectacles to the needy people. The most inspiring work of the department is the signature event, Kana Olympics, an Olympic event conducted for the visually impaired children, is an art-touching one and gives such a great opportunity for the optometry students to learn through experience. V-Opto was the first ever conference organized by School of Allied Sciences VMRF in the year 2018, and from then on every year it has been happening with a great success. This V-Opto 2026 is sure to create an everlasting impact on the upcoming practicing optometrist as they would gain knowledge and skills needed to stand apart from the crowd. My sincere appreciation to Professor Ms. Tamil Chudar, who has been the pillar of optometry, supported by Professor Mrs. Vanilla, Mrs. Ayamma, Assistant Professor Ms. Banu, and Assistant Professor of all departments and other faculties of optometry for the tremendous efforts in organizing this wonderful event. This commitment reflects the spirit of excellence that our institution continually strives to uphold. As we inaugurate this workshop, let us reaffirm our commitment to lifelong learning, innovation, interdisciplinary collaboration, and compassionate healthcare. I wish every participant a stimulating, enriching, and rewarding learning experience. May this workshop not only enhance your technical expertise, but also deepen your understanding of the profound impact your work can have on restoring lives. Thank you for the opportunity. I wish the workshop every success. Wishing you all happy learning. Good day.
Thank you very much, sir, for your insightful, thought-provoking and inspiring address. Your words have undoubtedly motivated us and enriched our understanding. Before we begin our today's technical session, let us take a moment to honor the distinguished experts whose presence has added immense value to V-Opto 2026. The success of today's workshop is made possible by the generous support and expertise of esteemed resource person. As a token of our heartfelt gratitude and appreciation, we respectfully invite our respected Dean Professor Dr. B. Sendil Kumar sir to kindly felicitate a resource person. May I invite Mrs. Priya Balasubramaniam and Mr. Satish Kumar to kindly come forward.
I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up. I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up and make a statement. I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up and make a statement. Everything I do so instinctive and so passionate. Every word I move so descriptive like an adjective. I got a vendetta against people who patented being negative when you should be getting after it. I got facts over tracks, this and that. Spitting slow, spitting fast. I could roast, I could gas. Think I'm okay at last, but I don't know if that can erase all the past. And the pettiness, a reflection of the emptiness. Hilarious, you think you're worth my time, you're delirious. Mysterious, because you hide behind a fake exterior. Inferior, you know I'll always be a bit superior. Get off of me, this ain't no humble brag. I want you to hear words, you
Thank
can
you,
say
sir.
them back.
We
I
sincerely
want you
thank
to
our
feel
esteemed
free from the
resource
chains
person
that last.
for
And to
graciously
believe in what you
accepting our
got, it was
invitation
built to
and
last.
being a part of V-Opto 2026. We look forward to learning from your expertise throughout today's session.
I had to do it all myself.
The facilitation of our esteemed resource person, we have come to a special moment of gratitude. It is our privilege to honor our respected Dean, Dr. B. Sendil Kumar sir, where visionary leadership, constant encouragement, and unwavering support has been instrumental in successful organization of this event. To felicitate our respected Dean sir, I would like to request all the faculty members of the Department of Optometry, School of Applied Health Science to kindly come forward and join us on the stage.
Mind games, but instead of say something not illogical, something that is topical. Rub it on and watch it go. Make yourself unstoppable. Dreams are irresponsible, but they're always possible. If you just believe, you could be so remarkable.
Thoughts in my head, a collage and they spread. I'll be great one day, going off of my meds. No, I'm not giving up, no, I'm not giving in. I will make it to the top, taking off in the wind. I gotta make it, I'm saving every day to taste it. I'm patient, but my mind, it can hardly take it. I'm chasing a dream that I've had for several ages. A vacant, modern kingdom for the taking.
Now that I've been put through hell, I never got anyone's help. I had to do it all myself.
I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up and make a statement. I don't ever slow up, no I don't.
Thank you, everyone. The field of ocular prosthetics is a unique blend of clinical expertise, artistic precision, and compassionate patient care. Learning from experienced professionals enables us to appreciate not only the science behind prosthetic rehabilitation, but also its profound impact on restoring confidence and quality of life. It is our great pleasure to introduce our first resource person, Ms. Priya Balasubramanian, founder of Iris Perfect Maxillofacial and Ocular Prosthesis Clinic, Chennai, an accomplished ocularist and optometrist with over 5 years of specialized clinical experience in ocularistry and oculoplasty. Ma'am completed her postgraduate diploma in oculoplasty and ocularistry from Brian Holden Institute of Optometry and Vision Sciences at LV Prasad Eye Institute, Hyderabad. She has previously served as ocularist and optometrist at Aravind Eye Hospital, Chennai, where she established and independently managed a dedicated prosthesis clinic, successfully rehabilitating over 300 patients with customized ocular and facial prosthesis. A passionate clinician and educator, Ma'am has been an invited speaker at several national conferences and workshops, sharing her expertise on ocularistry and ophthalmic socket rehabilitation. Her commitment to patient care, academic excellence, and innovation has earned her recognition, including the Appreciation Award for the most engaging lecture at the IVI conference. Ma'am, we are truly honored to have you with us today. We respectfully invite you to commence the first workshop section.
Had your refreshments, no? Yeah. Sorry, I was not able to be there. No problem. Check. Yeah. Volume కొంచెం. Volume. Check. ಇಲ್ಲ எனக்கு yeah works fine. But last வரைக்கும் கேட்கணும். Am I audible? Until the last? Okay. Yeah, sure. Let's start, right?
Hi, very good morning everyone. So, are you all excited? Yeah. Okay, so can we have it both in Tamil and English or fulla English, fulla Tamil? Okay. Okay, I am actually very excited for today's session. I'm also very happy that this is happening in Tamil Nadu for the first time as a whole workshop. So I'm equally excited. So I wish the same excitement with you guys. Okay, start panlama. Okay, so we are actually going to talk about whatever is here, healing beyond vision. So we are going to touch someone's heart through artwork. Okay, so who am I? I'm an ocularist. I'm specialized in the field of fabricating both facial and ocular prosthesis. I've been in this field for about 7 years now, and my private practice since a year. So today what are you all going to learn about is what is an anophthalmic socket, what are the grades of contracted socket, basically what are conformers, and when and where you refer a patient for a prosthesis, and a short video on how a prosthesis is made, and obviously you will have some workshop sessions where you will handle the prosthesis today. So basically these definitions are to be aware to know what is in this presentation. So I'll just give a quick gist on each definitions. Anophthalmia, as you all know, it's an absence of an eyeball. It can be unilateral or bilateral. So microphthalmia, which is often confused with phthisis bulbi, but both are different terms. Microphthalmia means the eye is there but it is small without any potential visual function, and this is generally by birth, okay, or a genetic defect. Whereas a phthisis bulbi is a secondary condition wherein the patient has a trauma or an infection leading to a vision loss or a blindness. So evisceration, enucleation and exenteration are three terms for surgical removal of the eyeball, and each surgery is different in its own aspect, which we will see in detail. The last one is an implant. Implant is nothing but a spherical tool. So if you remove the eye, the socket becomes empty. So we need something to replace inside. So implant is a tool to replace the volume of the eyeball inside. Okay. So this is a picture of a congenital and an acquired anophthalmia. If you see this, the first image, can somebody point any difference between an acquired and a congenital anophthalmia, whatever you see here? Would anybody like to comment? I can listen only eyeball. Okay. So okay, so congenital anophthalmia is where you see the eyeball hasn't formed at all. Okay, so there is no absolute eye opening. Okay, all you see is a very contracted eye. The horizontal palpebral fissure is very shortened and there is no opening of an eye at all. Whereas in acquired anophthalmia, we have surgically removed the eye. Okay, because of some certain condition, maybe an ocular cancer or a disfigurement, we have removed the eye. So the eye has grown normally so that you can see a very visible horizontal palpebral fissure. The eye has opened. So that is a basic clinical significance of congenital anophthalmia versus an acquired anophthalmia. So now these are the three terms of eye removal surgeries. Basically we are removing the eye for certain condition. Evisceration is nothing but is like scooping an ice cream from a tub. Okay, so you leave the extraocular contents like sclera and the extraocular muscle and scoop out only the internal contents like cornea, vitreous. So the outer layer stays. Okay, why an evisceration is needed? In cases where there is a painful blind eye, there is no visual potential, the eye is giving trouble to the patient and they want a better cosmetic outcome. Maybe a phthisis bulbi or an absolute eye which has gotten to an end stage glaucoma where there is no visual potential and it is causing functional difficulties to the patient, we refer them for an evisceration. Enucleation, whereas it is an extended evisceration. You remove it along with the external muscles and the optic nerve. Enucleation is primarily indicated wherein any oncology related problem, where there is a cancer in the eye, we refer for an enucleation, for the eye to not spread any infection to the brain. Exenteration is nothing but removing the whole of the contents including the eyelids. So you will see the pictures in the future. So it is nothing but we remove all the orbital contents including the orbital flat and everything where there is a sinus infection or a cancer which is in the fornix or behind the eyeball. Okay. Yes, very commonly exaggerated to save their lives, sir. So now congenital anophthalmia. So how do we rehabilitate them? So now this can be unilateral or bilateral. It is a genetic condition where the child has no eyes since birth. So now how do we rehabilitate them? We generally, after convincing them that there is no proper visual potential, we treat them for cosmetic rehabilitation. So in the eye where there is no space, we usually start with conformer expansion, wherein we term it as socket expansion treatment. So the child will undergo socket expansion for a period of time until we can place a small prosthetic eye of 14 mm. So until then, there will be a socket expansion with the use of conformers. Now the middle clear acrylic objects are called conformers. We put it inside the socket and with a timely interval, we keep increasing the size. Over a period of time, they might require few cosmetic surgeries wherein the fornix can be formed where we can place a proper cosmetic shell. Okay, so now this is the rehabilitative program for congenital anophthalmia. So now, any evaluation, how do you start a patient? You start with history taking. You approach the patient as to why have they come. Okay, so now these are the primary question. If you see an anophthalmic patient, this will be the primary history taking which we take. So why was there an anophthalmia? Was it an acquired condition or was it an congenital condition? Why has anophthalmia has happened? Why is there an absence of an eye? Okay, and then was there any prior ocular surgeries? Why it is important? Because to know whether it was enucleated or not, sometimes the patient might not go for a review or a PET scan, which is very much important for any cancer patients. They have to take it every 5 years. The whole body PET CT is very important. So that is why we ask why and what surgeries have been occurred. In case of an enucleation, generally the ophthalmologist will tell them to take a PET scan every 5 years and every oculist should be noted of their recent PET scan in their reports. So now any prior wear of ocular prosthesis was there? Have they gone to any trial like a cosmetic shell trial? So and then was there any pain, discharge and bleeding? Very important and indicative of any secondary disease which is happening inside the eye. And last is the protective glasses. So now this is how an anophthalmic socket will look like. So now what are the structures here? Is the eyelid. So now this as a whole is called as a socket. The internal part is mainly subjected as conjunctiva. Now you see the eyelids and the conjunctiva, you all already know there are 3 parts of conjunctiva. And then the last is the sulcus. The sulcus is nothing but a C shape here. Okay, this is very important in determining the cosmetic outcome of a prosthesis. So we say sulcus as C, the C that we will always see. Okay. So now how a socket should appear? It should appear healthy, which is pale and pink, as you can see here. A healthy socket will appear pale and pink. Okay, anything like this, you see a small layer of exposure there, that is nothing but an implant which is placed has been exposed. The conjunctiva has given away the sutures, so that is an unhealthy socket. Now, what to see in the socket? What to see in the center area? You see the health, is it normal or abnormal? And then secondly, you see whether the presence or absence of an implant. Now, how do I see whether an implant is placed or not? I simply place my hand over the sulcus area, the C or the lid crease which I see. Now, if we all touch our eyes, we can see something is filled, right? Our globe is filled. Now, if I feel the same in an anophthalmic socket, that means an implant is placed. Okay, sometimes it can be deeper, but if I feel something, that means that the implant is present. But if I don't feel anything, I feel the sulcus is empty and hollow, that means the implant has not been placed. Right? How is the implant? Is it center? Is it deviated? Or is it exposed like this in some conditions? So this is what I look in a socket. Now what are the other structures we saw? Next polar. Okay. Now we can all have a quick picture. Now this is how we describe the grades of contracted socket. So now how a socket is there. Now as you see in the first picture, you see there is a lot of space between the conjunctiva and the eyelid, right? So over a period of time, patients, when they use a temporary shell, or if they don't use anything, especially old patients or a child, the eye gets to contract. Okay, now when it contracts, this is the slower stage of contraction which you can see here. So now grade 0 is normal, like how you saw in the earlier pictures. The first is nothing but a shelving of a lower fornix. So the lower fornix loses its stability and it's just pout out. Okay, in that case, the patient cannot wear a prosthetic shell inside. Okay, when they look up, it might pop out and they will need surgeries to correct it. And in the second grade, along with the lower fornix, you see there is no fornix here at all. There is no specific line. So along with the lower ones, the upper one also get contracted. And over the next stage, what happens is the medial fornix gets contracted. And overall, the eye becomes contracted like this. Now, what is the last grade? Whatever you see here is nothing but we try to rehabilitate the socket with socket expansion surgeries. Like we place hydrogel implants, we try to make the fornices. So even after multiple trials, the eye get to contract. We call it as a post-enucleation socket syndrome. So that is called as a PES, a common condition where a prosthesis could not be placed. So we advise them for an orbital prosthesis. So when there is no eyelids or anything, we place an orbital prosthesis instead of an ocular prosthesis. Now these are all some examples of sulcus deformity. So as I said, the cosmetic outcome is not same for everyone. Each socket is different. Okay, so now if you see in the first image, the child was enucleated at an early age of 6 years. Okay, when he presented, he was 12 years and he came for a prosthetic eye. Now after we fit, can you see the sulcus is very deep? The implant is still there, but the sulcus is gone inside. That is because the implant size is smaller. So when they come for a cosmetic outcome, they will have a resultant smaller enophthalmus. So a small amount of enophthalmia or a smaller eye visibility will be there. So that is why we say the sulcus area determines the major cosmetic outcome of a prosthesis. In the second condition, where there is a sulcus deformity because of an aging. As we age, we all know the skin shrinks, okay, and there is no implant. So now what happens is we place a larger prosthesis called a crutch prosthesis. Just like crutch glasses, we give crutch prosthesis to hold the superior fornix or a sulcus area. So that will give the stability for the patient and we will have a good outcome of a prosthesis. Now the third condition is where there is a fracture. Okay, in every ocular fracture, every floor fracture, the eye sinks down because there is no floor support. So when the bone breaks, the eye tends to go down. So even if we try to place a larger prosthesis, the eye will always be smaller. Okay, so now a patient has come to you with a prosthetic eye. What are the things I see? Like I see how it is appearing. Okay, like example, color or modification should be needed. Now what you will see is whether it is a custom made eye or a ready made shell. Now how is the symmetry of the eyes? Now if you see, there is a mild ptosis of the right eye, but it is still not obscuring the visual axis, so it is still not cosmetically concerned. But if you see this condition where there is a lower eyelid retraction, so the prosthesis might fall off and needs attention. So not every symmetry related problem will need treatment, but certain symmetry related problems will need surgical corrections. Now as I said, each socket is different. In any absolute eye where the eye has become proptotic in a specific glaucomatous condition, we always try to give them a better cosmetic outcome by giving them a larger HVID, or in simple terms a larger cornea, to make the eye look similar. Now if you see the second image, there is a upper lid retraction, but I can still see the sclera. So what do we give them is a larger cornea and along with a spectacle minification. This is a common term which we use. So we give them a minus glasses to make the prosthetic eye look smaller. Now is the third condition, wherein you see a significant HPF difference. You see this eye is contracted, right? So a thiacical eye which was long standing, he didn't try a prosthesis. The injury has happened in his early childhood. Somebody would have told like you cannot place a prosthetic eye until you turn an adult. Okay, so they wait until 18 years and then come for a cosmetic eye. So now a custom ocular prosthesis placed after a long standing thiacical eye will look like this. So we can match the cosmetic outcome, but we cannot match the appearance of the eye because it will still look smaller. The common questions patients or people who come for rehabilitative care ask, how normal it will look, will my eyes move, will my lids close. So now what do we tell them is, a prosthetic eye will have a 30% movement, a contracted eye will have a lesser eye movement. Now when they close, is there any lack of thermus, and what is the condition of the prosthesis? Now if you see, this eye is not maintained properly. Now what happens, in turn they will have infection. So what is the condition of what they are wearing? Now these are conformers. Why is conformer used? Is because, as I said, we expand the socket with the use of conformers, and these are all serial conformers which are placed inside the eye post surgery. If you don't place anything, the eye will contract eventually. So now what are the types of prosthesis? So as I said, when you look at an eye, we see what is that prosthesis is made up of. Is it a ready-made shell or is it a custom-made shell? Okay, so now these are the basic types of prosthesis which you will see. And the third type is the orbital prosthesis, wherein there is no eyelids, so we make it along with the skin. Now, when and where do I indicate a patient for a prosthesis? When there is a disfigured blind eye, I call the patient. When there is no visual potential, like a thiacical eye, I first try a conformer over the patient or a stock shell over the patient. If they are comfortable, then we plan for a custom ocular prosthesis. So a disfigured blind eye is a common condition where a prosthetic service is needed without any surgeries. And the second condition is when the eye has been removed surgically for some condition, we rehabilitated them with a custom ocular prosthesis. So you will have a quick look on how a prosthesis is made. Bro, video play பண்றீங்களா? Cursor press பண்ணுங்க அது மேல. வீடியோ மேல. Full screen வைக்க முடியுமா? Yeah, no problem. No problem. Volume வருமா?
Technical acumen tailored to the sockets. The cosmetic and functional results render social and psychological rehabilitation to the patient.
Slideshow.
An ocularist fit.
இப்போ வீடியோ கிளிக் பண்ணுங்க.
Ocular prostheses are of two types. The stock eyes that are ready-made and available in bulk, and the custom-made prostheses which are made and carved to the size and shape of the individualized socket of the patient.
Sorry for the glitch, guys. ஒரு நிமிஷம். ஷார்ட் ஃபிலிம் போடுங்க.
Making and fitting of Ocular prostheses are of two types. The stock eyes that are ready-made and available in bulk, and the custom-made prostheses which are made and carved to the size and shape of the individualized socket of the patient. Making and fitting of a perfect customized ocular prosthesis requires a highly skilled technical acumen tailored to the sockets.
you want
The
to have a
cosmetic
good
and
knowledge, you
functional
have
results
to watch the video
render
keenly.
social and psychological rehabilitation to the patient. Prosthesis typically lasts for 5 to 6 years and might require repolishing or renewal for better finish. Resizing of the prosthesis in case of children is required as they grow and they need to be kept on a close follow-up. The team, comprising of oculoplasty surgeon and an ocularist, work together to provide the patient the best possible cosmetic restoration of the empty socket, thus filling the emptiness in their lives as well.
I would say it's worth it. At the end of the day, you get a better version of yourself.
So we'll be doing a few procedures here. You'll be seeing a whole procedure of how a prosthesis is made today, but half of it where you can paint an iris or a scleral painting, you'll have a hands-on experience on everything. Okay. So now, as they said in video, a prosthesis is not something which you place and then leave it alone. It has to be managed like your spectacles, or a timely intervention is needed. You have to replace an adult prosthesis around 5 to 7 years, and a yearly polishing is required, and monthly once they have to remove and clean it. Okay. In case it is a child, it might need replacement as the child grows. Okay, thank you. One.
மைக்ரோஃபோன்ல வந்து எடுத்துக்குது. ஆடியோ இன்புட் கேப்சர் மைக்ரோஃபோன்ல எடுத்துக்குது. இப்போ வரும் பாரு. ஆடியோ வருதா? கேட்கும். இதுல கொடுத்து வச்சுலடா.
இது அவுட் இருக்கு, இன்னும் இருக்கா ஆடியோ?
Senior lecturer at Government College of Optometry, Regional Institute of Ophthalmology and Government Ophthalmic Hospital, Chennai. Holds a degree of Master in Optometry, is a fellow of British Dispensing Optician and also holds an MBA in Marketing.
With extensive experience in spanning clinical practice and academics, he has served as a consultant optometry at renowned institutions including Chennai, Vasan Eye Care Hospital, Ashwini Eye Care Hospital, and Pacific International Hospital, Pawan, Italy. He has also associated with the Sankranethralaya Academy as a senior faculty and post coordinator for the fellowship in British Dispensing Optics and Master of Optometry.
I would like to thank the Dean, HOD of School of Allied Health Sciences of Vinayaka Mission Research Foundation for giving me this wonderful opportunity to talk on the customization in the spectacles and then dispensing a pair of the out-of-the-box dispensing called crutch glasses and then the belly prisms, Fresnel prisms. Okay, so I would it's good to see an incorporation of the ocular prosthetics with the dispensing aspect. I would like to appreciate the idea of bringing this together so that it will be an eye-opener for all the participants and the future aspiring optometrists. You can have this, we have the various options after we complete the V-Opto, but we can have this as one of the options to incorporate in our practice, because being in this field for the past 20 years, I can see a vast difference and the attitude of the students coming out after completing their UG. They have a various and a wide different interests. Okay, so someone because 20 years back when we completed optometry, we had option of only working in the hospital or the optical shops. Okay, so that was the time where the different aspects of optometry like vision therapy or low vision practice or contact lens practice were just booming up. Okay, so in this scenario, in today's scenario, that we have a wide opportunity where along with our regular optometry practice and the regular practice, we can also have an option of incorporating all these aspects so that we can have this as a career prospects. Okay, so before I start my topic, I would like to declare that if I mention any of the product names or any of the particular product, there is no financial interest involved in it. Okay, so before the principle of the optics. Okay, so it's basically a connection between the optics to the sight. Okay, but in today's topic and the discussions for the whole day, it is all about the cosmesis. Okay, because when we think about only the optics, sometimes we may have to compromise on the cosmesis part. Okay, so this is where the customization and improvising the cosmesis becomes a big challenge in today's scenario. Okay, so every time we are so much concerned about doing a good refraction, and we are so much concerned about the optics involved in each and every aspect of the activities we carry out in our regular practice. But apart from the optics, so what we forget is when a patient receives a pair of glasses or a pair of prosthetic lenses, they are more concerned about the cosmesis. Okay, so that is where the whole challenge lies. Okay, so how it all began. Okay, so everything, I'm a person who is very fond of all the history. Okay, so before we become an optometrist today in today's world, okay, so there are so many evolutions our professions have been, gone through. Everything started from, like, there were some of the articles shown that there are some professions called optocogens. Before the 1600s, there is someone called as optocogens who were involved in meticulously making a pair of spectacle frames or spectacle lenses out of animal residues. Say for example a horn from the animal residues, or any even from the bones. They even tried making the spectacle frames. Okay, so that is where from the optocogens the dispensing opticians, and from the dispensing opticians the today optometrists have been arrived. So everything. So if you look at when we are talking about the rehabilitation for some special patients, we are also talking about the customization. So it is not something very new to our profession. So when it began as an optocogens, because it also incorporated the customization. So customization is not something new for us. Okay, so the part of dispensing optics, we have 4 major parts of the various branches of dispensing optics. One is the lifestyle dispensing, occupational dispensing, vocational dispensing, and the pediatric dispensing. So lifestyle dispensing, as we all know, that it's a regular aspect, considering their occupational needs. We give them prescribe them a pair of progressive lenses, or prescribe them the anti-reflection coating, or a special type of lenses or the coatings, whichever they need. Okay, as per their lifestyle. And the occupational safety classes, like whenever they involved in such sort of activities, especially in the industrial setup, where they prone to get any blunt injury or penetrating injuries, we give them a pair of safety glasses or a safety face shield, where we can think about the occupational dispensing. The part whichever we are going to discuss today lies between the pediatric dispensing and the vocational dispensing. Okay, so because that is where the more of customization demands. Okay, pediatric dispensing. So what is the biggest challenge? Okay, so whenever we have a refractive error, we go to the hospital, we get the refraction done, and then we prescribe the glasses. Okay, so once we go to the optical shop, the set of frames, like the demo frames, will be there. We will choose one from the demo frames, and then we will fit the lenses onto that. Okay, we as a patient, they are not much concerned about the fitting characteristics of the spectacle lenses. They are more concerned about the look. But as a optometrist who involves in the dispensing optics and the customization, we have to educate the patient upon the fitting aspects and the importance of the fitting aspects. Okay, so in terms of pediatric age group, the frame characteristics in terms of the crest height, frontal angle, and the display angle, and the projection. So okay, don't get worried about it. We will teach you one by one how to take all these measurements. The crest height, frontal angle, display angle, and the projection. Okay, where the precision will not be accurate in the demo lenses which are available in the over the counter. Okay, so in that case we may have to try for a customization for the pediatric age group as well as the geriatric age group. So these were the measurements: crest height, display angle, frontal angle, and the bridge projection, which will ultimately help us to customize especially the bridge area of the spectacle frames. Because why we are so much concerned about the bridge area is because that is the age group where still the nasal bones will be growing. Okay, so suppose if you are not dispensing a good fit bridge area of the spectacle lenses, in that case definitely it is going to hinder the growth aspects of the nasal area bones. So this is the head width, temple width, and the pantoscopic angle. Okay, so you can make a clear difference out of these two pictures. Okay, so one at the left with a very proper fit in the nose bridge area, whereas if you look at the right picture, whereas the kid with a bigger, slightly bigger picture, because that is the trend now. Okay, because most of the frames, if you the spectacle wearers, you see they just wanted to wear a bigger size frames, where a lot of compromisation has been done in the bridge area. Okay, so you can see, we clearly see the difference here in the right side of the picture, where the nose bridge area is not at all perfect to the patient. So that is where the customization takes place. Okay, so this is what I was talking about. So out of the regular spectacles dispensing, sometimes we may have to dispense for different activities. Okay, like the today's topic, like crutch glasses, especially for the ptosis patients, and then the relay prisms or any sort of dispensing out of the regular spectacle comes under the vocational dispensing. Okay, so for today's workshop, okay, so what we are going to plan, to begin with the facial measurements, whichever we have discussed, and then how to make the customized frame model, especially using the bridge area measurements, and then finally, to see hands-on and with the touch glasses and the frontal prisms and the pelvic prisms. Okay, so touch glasses. So as you all know, it is basically, so can anybody tell me what is the meaning of crutch? Can someone give the mic to the students? Because I remember first speaker madam also telling something about the crutch, no madam? Crutch general meaning enna? General crutch edha solluvaanga? Mic. Uplift. Okay. This crutch is basically a kind of stick which will help us to தாங்கி நடப்பாங்க. ஸோ இப்போ அவங்களுக்கு ஒரு crutch கையில் ஒரு ஸ்டிக் மாதிரி வச்சுருப்பாங்க. ஸோ அப்போ அந்த மாதிரி ஒரு இன்ஸ்ட்ருமெண்ட்டை தான் வந்து crutchன்னு சொல்லுவாங்க. ஓகே, ஸோ தட் இஸ் வை the term has been incorporated here in the spectacles as the crutch glasses. Okay, so especially for the ptosis patient. So the mechanism here is, okay, so the ptosis crutch is a specialized non-surgical mechanical attachment which is basically fitted behind the parallel to the superior rim of the glasses. So it basically consists of a metal piece or a specialized nylon cord, thick nylon, where it will help the upper lid to be lifted. Okay, so the clinical benefits will be the device immediately restores the vertical palpebral aperture so that they can see very clearly without any obstruction. Okay, by bypassing the surgical intervention, it serves as a crucial and reversible solution for dynamic, temporary and systemic ocular conditions like okay, fine. So where the temporary ptosis in conditions like myasthenia gravis, where the ptosis keeps differing from time to time, and then the neurological conditions like Horner syndrome or the third nerve palsies, and then inoperable conditions. So for some patients they cannot operate for a sling surgery for ptosis. So in those type of patients, the crutch glasses will be very beneficial. Okay, so the types of basically there are only two types of crutch glasses. One is the adjustable and the second one is the fixed and the nylon thread. So the one which I brought here for the workshop is the nylon and the fixed thread option. Okay, because nowadays most of the technicians are making only the nylon and the thread option. So the temporary one, only very few technicians are there to, like I said, like the optocones, how they become obsolete from the optical industry. Nowadays the technicians are also becoming obsolete. So it's very hard and very tough to find a technician who can attach the adjustable metal crutch glasses. Okay, so this is what I was talking about, a nylon cord crutch, and it is basically like a fixed and the flexible one. So basically what is the frame selection? So frame selection should be a very sturdy and a strong frame where we can have the provision to fit the crutch. So basically it should be a rigid metal or it should be a thick plastic. Okay, any sort of plastics. Okay, some of the technicians, they are not able to do crutch in the TR90 because in today's scenario most of the plastics are TR90 frames. Okay, so some of the technicians here in Chennai, they are not able to do the crutch glasses in the TR90. I don't know what is the reason, but it can also be done on the TR90 if they are trained. Sensor enga irukku? So So the nylon cord, whichever I was talking about, it should be a medical grade wire. So it is medically fashioned, and it should be very flexible, and very importantly, it should be hypoallergenic. So because it is going to have a direct contact with the skin, so the material whichever we are going to use as a cord to be fixed as a crutch, so it should be hypoallergenic on the skin, and it will be usually 1.5 to 2 millimeter of thickness. And the coating, okay, suppose if you are using a fixed metal crutch, so in that case, to avoid the metal being coming into contact with the skin, so we can even think of a sleeve where it can be covered or inserted over the metal piece, so that we can avoid the direct contact with the skin. So before how to start, okay, so once you have the ptosis patient with you and once you plan to go for a crutch classes, okay, so how to go about it, okay? So first of all, the entire process begins with the frame selections. So once you are done with the frame, okay, so we have to make the patient wear that frame, and from that frame do all sort of adjustments first, and then I will also show you how to do it during the workshop. So once I finish with all the slides, I will also show you the video demo, and then I also have some of the volunteers will be coming near to you, around 10 volunteers are there. Okay, so they will be coming near to you, and then they will also help you, okay, to have the idea. So we can even make the measurements using a normal scale ruler. Okay, so with the selected frame in place, okay, so we can measure how much length you want, how much depth you want in the crutch, and then we can proceed. Okay, so what are the complications we may get with the crutch? By using the crutch glasses, we are, just by lifting the little higher with the larger palpable fissure height, okay. So there are chances that we have to make sure that with the crutch in place, they should have at least a minimal amount of blink with the crutch in place, because we cannot dispense a pair of crutch glasses without making the patient to blink, okay. So that will definitely cause a severe dry eyes. So in that case, even with the minimal amount of blink, there are chances that they may feel some dry eyes. So in that case, we may think of prescribing them some lubricating eye drops, and then we have to train them. Okay, in-house training is very, very crucial, because you cannot dispense a pair of crutch glasses like the usual regular traditional glasses. Okay, so in that case, in-house training. Okay, how to insert the crutch glasses, how to go about it, and then how to remove, and how frequently they have to remove the glasses, because if I see I can wear this in the morning and then wear it until tonight continuously without removing glasses. Whereas the crutch glasses has to be removed on a frequent intervals, so that it has to facilitate the blink, okay, complete blink. So only then they can get rid of the dry eyes. And then initial period, as I mentioned, you have to make them wear the crutch glasses gradually by making them to wear 2 hours per day on the first day of getting their crutch glasses. Maybe on a second day you can make them to wear for 4 hours. So like that we have to gradually, like how we used to train the patients for contact lenses, the same way we can also train for the crutch glasses. Okay, all of a sudden if they keep wearing continuously on a very first day itself, it will be very tough for them. So sometimes we may even have the dropouts. Okay. So I think I have discussed the excessive dryness and eyes. We can the root cause will be the incomplete blink mechanism. So in that case, we have to teach them how to have the habit of blinking with the crutch glasses in place, or any localized skin tenderness or excessive focused pressure. Then we have to recontour and rework the entire crutch whichever we have made. Any eyelid spasms like blepharospasm, the temporary stop and start. Okay, so they can stop wearing the crutch glasses for some time, and then they can restart wearing the crutch glasses. So this is one of the crutch which we have recently dispensed from our hospital. Okay, so this looks little different from the one whichever we have discussed before, from the fixed metal crutch and the flexible and the nylon cord crutch. This is something which is coming new in the market. Okay, we got this from the local market, and I will also show you some videos. Sir, play பண்ண முடியுமா? கீழ ஒரு cursor மாதிரி play cursor மாதிரி. You can see the patient how he is wearing, okay, and how he looks now with the crutch glasses. So can you please replay the video, sir? It's just a few seconds only. Okay, so we got a proper consent from the patients that we are going to showcase in the conference, and he also agreed. Okay, sir. So these are the resources. Okay, so next we move on to the Fresnel prisms and the lenses. Okay, so how many of you done or dispensing prisms, or have done dispensing glasses with the prisms? Any PG students here? In your practice or in your UG days, have you prescribed any prisms for your patients? Any PG? How many PGs are here? PG students. Okay, no theoretical questions, only practical questions you can answer. எத்தனை நீங்கள் இது வரைக்கும் நீங்கள் யூஜி ஃபுல்லாக முடிச்சிருப்பீங்க, ஒரு சிலருக்கு உடனே ஃப்ரெஷ்ஷாக ஜாயின் பண்ணியிருப்பீங்க, ஒரு சிலர் கொஞ்சம் வருஷம் பிரேக் எடுத்து ஒர்க் பண்ணிவிட்டு ஜாயின் பண்ணியிருப்பீங்க. இது வரைக்கும் ஏதாவது ப்ரிஸ்கிரைப் பண்ணியிருக்கீங்களா? என்ன ஒருத்தர் கூட இல்லை? மேடம், எஜுகேட்டர்ஸ்? Okay, madam. Okay. In your practice, madam? Okay. Ma'am, how about you, madam? Okay, fine. See, it's a less proportion, I can understand, but very rarely we do prescribe the prisms for our patients, especially when you involve yourself with the binocular vision clinics. We may prescribe in large numbers, but in a regular day-to-day optometry practice, we do prescribe very less. But this is also another eye-opener for us. Okay, as an optometrist, what are the responsibilities we have? What are the things we can carry out, and what are the things we are missing out in our practice? Okay, so we have no boundaries. Okay, so with the rules coming in place, or forget about the past. Okay, so we can even think of exploring something out of away from prescribing the regular glasses. So some we can manage. Suppose in case if you are not able to manage those patients in your practice, kindly please do refer them to the next higher level centers or the tertiary centers, so that the patient will not be missed out any sort of medical assistance. Sorry. Just a minute. Okay. So, how does the prism works? Fresnel prism works. So basically, it is all about the optics of the general prisms. So இப்போ நம்ம யூஜி படிக்கும்போதெல்லாம் நம்ம படிச்சிருப்போம், ஸ்கூல் டேஸ்லேயே படிச்சிருப்போம். ஸோ whenever a light travels through the prism, it bends towards the base and the image shift towards the. So when we see any object through the prism, the image will obviously get shifted towards the apex, right? Okay. So it is basically the general optics. So what is so different with the Fresnel prisms? So it is unlike the regular prisms where it comes with a larger thickness, especially in the base area. Okay, when you going to dispense a pair of prisms for a temporary basis, not on a permanent basis. Okay, if there is a condition where you are going to prescribe the prisms for only for another 1 month time or next 2-3 months, so in that case, or only for a shorter time. Okay, so in that case we may think of prescribing the Fresnel prism. Suppose in case if they wanted to wear, if they have to wear the prisms for the longer duration, then we may think of the grounding prisms. So in that case we can even prescribe the regular grounding prisms, which can be incorporated with the manufacturing of the glass lenses itself or the plastic lenses itself. So on a temporary basis we can think of the Fresnel prisms where the entire thickness of the base will be reduced to close to 1 or 1.5 millimeter, not more than that. Okay, so how does the prism works? Okay, you all know that you must have studied during your UG days that the deviation produced by the prism not depends upon the thickness of the prism, whereas rather the deviation produced by the deviation of the light rays produced by the prism rather depends only upon the refractive index in which the material has been made and the apical angle. Okay, so basically the optics lies only in the refractive index and the apical angle. Okay, so considering these two facts, that the entire principle of the Fresnel prism works. Okay, so without considering the thickness, we are concerned only about the apical angle and the refractive index of the material in which we are going to make the Fresnel prisms or any sort of prisms. Okay, so in that case, considering only the apex region and making that to be placed on a regular sequence on a thin sheet of plastic or thin sheet of glass, we can imagine how the Fresnel prisms are made. So this is one of the prism. I have also bought one today. I will also show you through the demo videos. Okay. Okay. So usually we prescribe prisms like on a regular basis. We prescribe in base up or base down vertically, and if it is horizontal, then we prescribe base in or base out for the right eye or left eye, whichever we want. Okay. Suppose Fresnel prisms can also be like other prisms. A Fresnel prism can also be oriented in the oblique meridians. Okay. Suppose for some of the conditions we may have to prescribe both vertical prisms as well as the horizontal prisms. Okay, so then we have to know about the prism orientation method. Okay, so there are three methods being followed so far for the orientation of the prisms. Okay, so the old one is the old English method, where the prism orientation will be categorized in 4 different directions, and then the new English based notation, where the prism notation will be only in 2 different base directions, whereas what we follow today, okay, even 2 weeks back I got a prescription from one of the institution with the prisms at oblique, okay, say somewhere around 210 degree or 280 degree, like that. Okay, I remember Surya, you were asking about some of the questions out of the presentation. Okay, have you asked it to the students? You will ask. No, you were telling something about pre and post. Okay. Okay, so you must have received these questions, okay, regarding the base notation of the prisms. Okay, so what we follow now is the 360 degree notation. Okay, so no need to confuse about the 4 quadrants or the 2 directions. Rather, it is a single and very clearly notation with the 360 degree notation. Okay, so for example, if it is base up in the right eye, we can simply mention as base 90. If it is base down in the right eye, we can simply mention as base 270. If it is base out in the right eye, we can mention as 180. Okay, same 180, if you mention it for left eye, it will be base in for the left eye. Okay, so horizontal and vertical orientations may not give you some confusion, whereas apart from vertical and the horizontal orientations, that is where we need to know about the 360 degree notation. Suppose if you are going to prescribe a prism with oblique meridian, 360 degree meridian only will give you a clear idea of, especially to differentiate from the right eye to the left eye. Okay, so this is what I was talking about. So if in case if you are going to prescribe both vertical and the horizontal prisms, so as an optometrist, it is also our responsibility to tell the instruction to the manufacturers. Okay, so because sometimes the manufacturers also may not know like in what orientations they have to make the prisms. So in that cases, before making the grounding prisms, the Fresnel prism plays a very vital role in judgmenting and giving the training to the patients, especially for the oblique prism, because the most of the grounding prisms in today's scenario are mostly horizontal and vertical. Okay, so very rarely, we may also have to prescribe the prisms in the oblique meridian. In that case, straight away going to the grounding prisms with the glasses or the plastic lenses will be little tough for the patients to understand. Okay, so in that case, the Fresnel prism can be incorporated in your in-house training, and you can make the patient to feel how they are going to look through the lenses. So in that cases, it's a basic mathematics involved in it, like the Pythagoras theorem. Okay, so the resultant prism can be calculated using the formula, the square root of px square, that means the horizontal prism square plus vertical prism square, and the base orientation from the tan theta is equal to vertical prism by horizontal prism. Okay, so I have calculated one here. just for your understanding. Okay, so in front of the right eye we are going to prescribe both 4 prism base in, so that is the horizontal prism, and 2 prism base down, that is again a vertical prism. So we are going to prescribe both horizontal and vertical for the same right eye. Okay, so in that case the single resultant prism will be 4.47 at 333.5 degree axis. Okay, so like how we mentioned the axis for the cylindrical lenses, so this you can understand as axis for the prisms as well. So 330 for the right eye. Okay, so again just for your easy understanding, 4.47 right eye at 333. So you can imagine 333 axis in this one. Okay, so if you don't follow the 360 degree notation, then it will be very difficult for you to convey this to your manufacturer. Okay, so that is where you need to know about the 360 degree notation. Okay, so and then the primary clinical indications, as I already mentioned, for the establishments and to get rid of diplopia, especially in the especially for a transition period or a temporary period, and in the as I already mentioned, the dynamic trial period. Okay, so whichever before giving constant prisms or the grounded prisms with the glasses, the Fresnel prisms in the in-house training will serve as a very big educational tool, and will make the patient to understand the need and how they are going to experience with the glasses, especially with the first time when they get introduced to the prisms. And then the visual field mapping, especially when we talk about the Fresnel prisms for the visual field rehabilitation. Okay, so we have to teach them about through the prisms, especially the Pelli prisms or the Fresnel prisms, how they are going to see things, especially if they suffer from a binasal hemionopia or a left homonymous or a right homonymous hemionopia or bitemporal hemionopia. Accordingly, we have to keep the Fresnel prisms without disturbing their distance vision in the primary case. So we have the option of utilizing either the top portion or the bottom portion of the spectacle lenses. I will also show you in the demo. We will also show you how to paste the Fresnel prisms onto the spectacle lenses. Okay, so before we think of prescribing prisms, okay, so sometimes we have the provision of dividing or compounding the prisms between the right eye and the left eye. Okay, suppose instead of giving huge prisms in front of only one eye, okay, suppose if they have right esotropia, so for right esotropia நம்ம என்ன கொடுப்போம், base out கொடுப்போமா. Okay, so suppose 30% base out, so for 30% base out rightலயே நீங்க கொடுத்தீங்கன்னா you can understand how awkward it will be looking. Cosmosis big challenge, correct இல்லையா? So இப்போ நம்ம right eye என்ன பண்ணலாம், 15% in the right eye, 15% in the left eye, we can divide and give. Correct இல்லையா? புரியுதா நான் சொல்றது? Okay, so we can divide between the each eye. So in that case, suppose if you are going to prescribe a lesser prism only in front of one eye, so we have to find the dominant eye. So the prism can be tried over the non-dominant eye first if they accept. So otherwise we can even try on the dominant eye as well. So you all must be knowing how to find out the dominant eye, right? There are many procedures how you can find out the dominant eye. Again, the frame selection. Okay, so the material whichever you are going to choose for making the Fresnel lenses, like the material of the lenses. Okay, so in that case, the ideal would be the glass. Suppose if you are not able to fix on the glasses, we can even think of fitting or replacing that on the plastic lenses as well. Okay, so the in-house trial. Okay, so what it concerns is the prism adaptation trial. Okay, so we have to fix or paste the Fresnel prisms over the spectacle lenses, whichever we are going to dispense to them, and then with that you give them the training for distance vision for initial sometime, and then intermediate vision, and then near vision. And then once they are very clear with the distance vision and the intermediate vision and the near vision, one thing should be taught to them very meticulously, that compared to the regular grounding prisms, the Fresnel prisms are going to have a lesser reduction in the contrast sensitivity. Okay, suppose when with the grounding prisms, if they can read 6:6, with the Fresnel prisms in place, they will read only up to 6:16 because of the poor contrast. So can someone make out what would be the reason why they have lesser visual acuity or poor contrast sensitivity with the Fresnel lenses or Fresnel prisms? ஏதாவது யோசிங்க, கேட்டுக்கிட்டே இருந்தால் கேட்டுகிட்டே இருக்கலாம், தூக்கம் வரும். Fresnel prismலையும் லென்சஸ்லையும் ஏன் விஷுவல் அக்யூட்டி கம்மியாகும்? கான்ட்ராஸ்ட் ஏன் கம்மியாகுது? அதை நம்ம எஜுகேட் பண்ணோம். ஒய் Fresnel material, because it is anyway it is going to be transparent, but the mechanism நான் சொன்ன பாத்தீங்களா Fresnel prism ஓட mechanism high cylindrical high prisms தான் நம்ம locate பண்றோம். Okay, just a minute. Groove, somebody mentioning about groove. Yeah, you are right. So நம்ம அந்த திக்னஸை ரெடியூஸ் பண்ணி சீரீஸ் ஆஃப் அந்த அபெக்ஸை மட்டும் தான் நம்ம பிளேஸ் பண்ணுறோம். ஓகே, ஸோ தேர் வில் பி ரிட்ஜஸ். ஸோ அந்த ரிட்ஜஸ் வந்து என்ன பண்ணோம்னா இட் வில் டெஃபினெட்லி ரெடியூஸ் தி கான்ட்ராஸ்ட் சென்சிட்டிவிட்டி அண்ட் தி visual acuity. So that is where you have to educate the patient very priorly that you are going to have a lesser visual acuity with the Fresnel prisms or Fresnel lenses in place. Okay, so otherwise you all know that today's people's expectations are very high, especially with the vocational dispensing. Okay, so they always come, like whenever they give order to you or whenever they come consultation to you, they come with the mindset that they all the problems will be rectified with the glasses and they will look like a normal person. Okay, so that is not going to happen. So that is where, as the prior speaker also telling about the counseling. Okay, so you have to counsel the patient. Okay,
one doubt actually.
Yes, madam. Yes, madam.
Say we are giving oblique Fresnel prisms.
Yes, madam.
So how are we going to give? Is it going to be, it's a resultant type?
Yes, madam.
It's not going to be completely on horizontal, it's not going to be completely.
Yes, madam.
So if it is going to be, where will be the apex, where will be the base, and is there any?
It's like a usual prisms, madam. Okay, so for example, ஒரு patient
we can take more resultant prism with 333 degrees.
Yes, ma'am.
So how are you going to place the prism over there? Is it going to be
base towards the 333 degree. Yes, madam. Yes. Because we always mention the orientation of the prism by means of the base. So when we say base prism 90 or prism 270, it ultimately means the base. So base, so in the example whichever we have discussed, the base should be placed at the 333 degree. Yes. Okay, so in-house training plays a very crucial role to make them understand the visual acuity and the quality of vision which they are going to have with the pair of Fresnel lenses or the prisms. Okay, and make sure that they should have a reasonable amount of binocular single vision. Okay, so with the prisms in place or with whichever the Fresnel prisms or it should not hinder the binocular single vision of the patient, especially when they are involved with active lifestyle. Okay, so what is the step-by-step application? Okay, I will. I think it's better I can demonstrate practically rather than discuss. So, like I already mentioned, so Fresnel prisms or the lenses definitely will incorporate a larger amount of chromatic aberration. Okay, and then while cleaning or maintaining the Fresnel prisms will be very tough, because maintaining the regular spectacles itself will be tough for us, because if you can randomly go and pick, we can easily see fingerprints or smudges over the spectacle lenses and the dust. Okay, whenever we travel, we always obviously attract some dust. So in that cases, maintaining the Fresnel prisms, so with the ridges in place, it can easily attract dust. And the toughest part here is when the dust gets stuck over the ridges of the Fresnel prisms or the lenses, it will be very tough for you to clean. So you have to be very gentle, and you have to we can even apply the normal water to clean it. So we don't need any specialized solutions. Okay, and then visual adaptation, so that plays a very vital role. Okay, so this is just the Google Gemini based comparative picture table to show you. Okay, so traditional thick prisms will be little thick and heavy, whereas the Fresnel prisms will be weight less than 1 gram. Okay, so apart from the regular weight of the spectacles, the weight which it can add will be maximum 1 gram or 2 gram, not more than that. And the additional classes, we can even the clarity. Okay, so as I already mentioned, the contrast will be little high in the regular grounding prisms, whereas the Fresnel prisms, it will have the reduced contrast sensitivity. So we can even think of how we do the prism bar cover test. We can even have in the in-house training we can have the alternate cover test to confirm the ocular motility with the prisms in place. So this is what I was talking about. So we can make, you can select a frame and with the regular prescriptions in place, because if the patient have a high astigmatic refractive error, so in that case all the remaining part, apart from the regular spectacles, all the refractive error part will be incorporated in the regular spectacles, and on top of it we are going to paste the Fresnel press-on prisms. Okay. So first initially you have to trace the outline of the frame rim of the right eye, whichever eye you are going to choose, right eye rim or left eye rim. You have to trace it manually, and accordingly you can cut the outline of the Fresnel prisms, and then by using a simple water, normal water, you must have seen people applying the PPF coating over a car surface, bike surface, PPF coating. Now normal temper glass என்ன பண்றாங்க, just ஒரு ஸ்ப்ரே மாதிரி அடிச்சிட்டு க்ளீன் பண்ணிட்டு அதுக்கு மேல ஓட்றாங்க இல்லையா? Almost similar to that. Okay. No big the pasting, adhesives, அதெல்லாம் எதுவுமே கிடையாது. நார்மல், because anyway on a temporary basis தான். So ஒரு 1 month அப்புறமாவோ இல்லை 3 months அப்புறமாவோ நம்ம ஏதோ அதை ரிமூவ் பண்ணுற மாதிரி இருக்கும். So it should be easy to remove. So these are the resources. Next, pelli prisms. So it is almost similar to Fresnel prisms, but the only difference here is it is especially going to be dispensed for field remediation purpose. Okay. So especially, as I already mentioned, for someone who is suffering from binasal hemianopia, or bitemporal hemianopia, or left homonymous or right homonymous hemianopia, in the very hemianopia patients, field remediations ka nama pelli prisms. But in my practice, I have never dispensed pelli prisms like the one which is shown in the second picture. So that is a basic traditional pelli prisms, okay, which was invented by Pelli. But in our practice, what we have maintained is, because getting a pelli prism manufactured and import from other countries will be little tough. Okay, so that is where we in our practice we have dispensed a pair of Fresnel press-on prisms almost similar to the one which was suggested by Pelli. That was shown in the first picture. Okay, so you can it's positioning the Fresnel prisms will make you to make the replica of the pelli prisms. Okay. So it is basically designed by Dr. Eli Pelli for the high Fresnel prisms from 40 prism diopter to 57 prism diopters. Okay. So 40 prism diopters, if you make in ground in prism, you can imagine how thick it is going to be. Even if you divide between the right eye and the left eye, the 20 prisms, it is definitely, obviously it is going to look awkward. Okay, towards the edges wherever the base are going to be placed. So it is basically for homonymous hemianopia or patients suffering from traumatic brain injury and the mobility and the spatial deficits. So again, the in-house training with the pelli prisms or the Fresnel prisms, especially for the field remediation, needs more training than the regular Fresnel prisms, because here, unlike the entire Fresnel prisms being given for the orthoptics purpose, here the prisms will be placed in a certain position, okay, where they have to understand the orientation and the amount of displacement whichever they are going to experience through the Fresnel prisms. So in that case, in-house training for the field remediation becomes much more challenging than prescribing the Fresnel prisms for the orthoptics purpose. So this is where, okay, you have to tell, it is basically manufactured as base out in one of the prism and then base in the other prism, or if it is in the oblique, even in the text we have come across pelli prisms that can also be oriented in an oblique meridian. So say for example, one of the pelli prism will be 45 degree base and then other pelli will be at 135 degree. So but I have never seen any pelli prism. I have seen only the horizontal placed pelli prisms during my practice. So what is very challenging here is the prism boundary demarcation. Okay, without disturbing their primary gaze visual acuity, we have to train them, and then we have to position the Fresnel prism in such a way it should not hinder their regular visual habits. Okay, so I think I already mentioned about the in-office trial training, especially for the orientation, spatial orientation and mobility. Okay, so during the systemic patient training, we can teach them about the saccadic scanning and then look and touch. Okay, sometimes if they are approaching any closer objects, so to make them understand how they are going to have that displacement, especially with the prisms in place. So we can even train them with the near objects so that they can touch and feel where the image is going to displace. And then sometimes the diplopia adaptation becomes a very big challenge. Okay, whenever we are introducing prisms for the first time, some of the patients, whenever they are moving the gaze from the normal spectacles to the pelli prisms or the Fresnel prisms, that is where during the transition from the clear zone to the Fresnel prism zone, sometimes some of the patients may have the diplopia effects. So in that case, we have to teach them how to handle the diplopia and then how to get rid of the diplopia in the initial days when they get trained with the Fresnel prisms. Okay, so this is the one which have the sectoral placed Fresnel prisms. Again, I told you, okay, you have to teach them like the displacement with the Fresnel prisms and the normal viewing through the primary gaze. So these are the resources. So once again, I would like to thank all the faculty members, Dean, HOD of the Vinayaka Research Foundation and School of Allied Science. I would like to thank my organization, Regional Institute of Ophthalmology and Government University, for giving me this wonderful opportunity. Thank you. So, faculty, straight away start pannidalama. So what we have planned is, since we have a huge crowd, I can have a volunteer here. What I am going to do now here on the stage, simultaneously you guys can also try and do it over there in the groups. Okay, so I think the tables are also segregated in groups. Okay, so we will have one volunteer in each of the tables, and they will also help you there. Okay, so one of the volunteers can come over to the stage. ஒரு சார்ட் பேப்பர்.
சார் இதை மட்டும் பாக்கெட்டில் வச்சு.
போதும்மா. இதை வச்சுட்டு கஸ்டமைசேஷன் இது ஃப்ரெனல் ப்ரிசம் ஸ்கேலுக்கு நீங்கள் என்ன பண்ண டிஸ்டன்ஸ் பிட்வீன் நான் அதை இங்கே காமிச்சிடுறேன், அது அவங்கக்கிட்ட எக்ஸ்பிளைன் பண்ணால் போதும். எத்தனை பேருக்கு அது தெரியுன்னு தெரில. ஓகே. நீ எந்த குரூப்போட இருக்க? இங்கே ஃப்ரெண்ட்லியா? ஓகே. இல்லை இங்கே இங்கே ஒன்றும் பிரச்சனை இல்லை. நீ இப்போ இந்த 2 டேபிள் பார்த்துக்கிறியா? 2 டேபிளா? ஓகே ஓகே ஃபைன். ஓகே, ஷால் வி ஸ்டார்ட்? வாலண்டியர்ஸ் ரெடியாக இருக்கீங்களா? ஓகே, ஹாவ் யூ ஆல் காட் திஸ் சார்ட் பேப்பர்? இந்த சைஸில் சார்ட் பேப்பர் வந்துடுச்சா? ஓகே. ஸோ யூ கேன் ட்ரை ஆன் யுவர் ஃப்ரெண்ட்ஸ் ஹூ ஆர் சிட்டிங் நியர்பை டு யூ. ஓகே. ஸோ இப்போ இதுலேருந்து நம்ம என்ன பண்ண போகிறோம் அப்படின்னா, ஒரு பிரிட்ஜ் ஏரியாக்கிட்ட நம்ம எப்படி அந்த மெஷர்மெண்ட்ஸை பண்ணிவிட்டு அதுலேருந்து நம்ம ஒரு கஸ்டமைஸ்டு நோஸ் பிரிட்ஜ் ஏரியா தான் பிளேஸ் அ வெரி க்ரூஷியல் ரோல். ஸோ அப்போ அந்த நோஸ் பிரிட்ஜ் ஏரியாவில் நம்ம எப்படி அந்த கஸ்டமைசேஷன் பண்ண போகிறோம். ஓகே. ஸோ இதை பார்த்துட்டு நெக்ஸ்ட்டு வி ஆர் மூவிங் ஆன் டு ஹவு டு பேஸ்ட் தி ஃப்ரெனல் ப்ரிசம்ஸ் அண்ட் தி lenses and we are going to have the hands on the crutch glasses as well. புரியுதா? ஸோ டு பிகின் வித் நம்ம இந்த ஃப்ரேம் கஸ்டமைஸ்டு ஃப்ரேம் மேக்கிங்கில் நம்ம ஸ்டார்ட் பண்ணலாம். ஓகே. ஸோ இப்போ ஒன்ஸ் நீங்கள் இதை எடுத்துட்டிங்கன்னா என்ன பண்ணணும்னா, நெக்ஸ்ட்டு யூ ட்ரா எ லைன், ஹரிசாண்டல் லைன் எக்ஸாக்ட்லி டு த சென்டர். ஸோ இப்போ இதுக்கு ஒரு லைட்டாக பென்சில் இருந்தால் பென்சிலில் ட்ரா பண்ணிக்கோங்க. ஓகே. ஸோ சைமல்டேனியஸ்லி நான் ஒரு ஸ்டெப் பண்ணும்போது நீங்களும் ஃபாலோ பண்ணிங்கன்னா இட் வில் பி ஈஸி. Okay. PD ruler இருக்கா? PD ruler or any mobile, even you can use your mobile phones. ஹரிசாண்டலாக ஒரு லைன் வரைஞ்சிக்கோங்க, அவ்வளோதான். இருக்கப்பா. என்ன பண்ணுறது? ஓகே ஓகே சார். Students, participants, please listen here. Please don't discuss among yourself because we are running out of time already. Okay. If at all, if you have any doubts, the volunteers are there to help you. You can ask the volunteers. Okay. So have you all made the horizontal line like this? Okay. So the first part, you have to determine the crest point. Okay. So the crest point is basically the center of the nose bridge, which is going to be the most bearable part whenever you keep a horizontal object like this. Okay. So the point whichever touches first exactly at the center of the nose bridge. So that is called the crest height. Okay. So what you can do is, just by keeping a regular ruler like this horizontally, you can determine the crest point. Okay. From the crest point, okay, you can determine the distance of the lower lid margin for the individually for the right eye as well as for the left. Rarely we may have some differences of the crest height from the right eye to the left eye, but generally we do have the same crest height between the right eye and the left eye. Okay. So it's a very simple step.
So it's a very simple step. Mic. Okay. So take any horizontal ruler like this, place it horizontally, and you can keep slide down from the top. The place wherever it touches exactly at the center of the nose bridge, that is exactly called the crest point. Okay. So first point is to determine the crest height. So from the crest point, you can measure how far is your lower lid margin of the right eye and the left eye. So in this case, okay, look straight and make the patient comfortably and make them to look in the primary gaze. Okay, straight ahead position. So for me, the crest height for the right eye is 5 millimeter. In the left eye also 5 millimeter. Okay. So from the what you do is, so next step, you make a vertical line. Make a vertical line. From the vertical line, you mark the crest height. Crest height point. Like this. Sir, you video la kamchiringla. தெரியுதா பேக்கில் பண்ணுங்க. Have you all done with the crest point measurement and the crest height measurement? I know it's tough to understand at the very first step, but like once you get exposed to all these terminologies, there are n number of videos available on YouTube. You can go through that anytime. You can just have the hands-on. Have you all done with the crest height measurement? Have you all made this crest height markings here? Done for everyone? Okay. So next step, we need a specialized ruler called Rees Fairbank ruler. Okay. You can just have a look at this. This is called the Rees Fairbank ruler, especially used by the dispensing opticians to measure all sort of facial measurements. And this will also have the provision to measure the apical radius of the nose bridge area, okay? Because that is where most of the demo frames over the counter will not suit you exactly for the particular individuals. Okay, so in that case, you can measure the apical angle. Okay, so you can randomly select that as 8 millimeter or 10 millimeter for today's purpose. But there is you have to get to know that there is a ruler like this can be used for measuring the facial measurements. Okay, including the apical radius. Okay, so I will show you the live demo how to measure the apical radius. Okay, so the semicircle kind of grooves are there. You can keep it over them and then you can match it. Okay, which you have to give them a slight slope angle. Okay, so in this case it has the provision for measuring 5 millimeter to 12 millimeter. Okay, so 7 millimeter will be little tight for him. So I find that 8 millimeter fits him with the good apical radius. Okay, so on an average for most of the adults, the apical radius lies somewhere between 6 millimeter to 9 millimeter. Okay, so for my volunteer it will be 8 millimeter. So what the next step, what you have to do is, you can even use the regular ruler. From the ruler you can mark the 8 millimeter semicircle like this. Like this. தெரியுதா மேடம்? everyone see this on the chart paper? From the crest height, from the crest point, you can make the apical radius first. Done? See, the idea is you should have this 8 millimeter circle. Okay, so using a normal scale or a ruler, you can have 4 millimeter left of the center and 4 millimeter right of the center, and you can make a circle. In case if you are confusing about how to go about 7 millimeter or 8 millimeter without a ruler, you can divide 8 millimeter, 4 millimeter on either side of the center line, and then you can make a circle from the crest point. Is that clear? Is that clear? Okay, so once you are done with that one, we have to measure the distance between the rims. Okay, so that means if you are going to make the patient wear the spectacle lenses. Okay, so madam, you can try and zoom this bridge area, nose bridge area. Okay. So if you can see this frame on his face, you can see a little gap, and you can also see that the frontal angle and the slope of the right side and the left side is somewhat little different. Okay, you can see that I can see very closely that the slope of the right side of the nose bridge is somewhat okay for him, whereas the slope of the left side, if you can see, there is a slight, I don't know how many of you can make out from the projector screens, but I can make out, seeing watching from a very closer distance, I can see that the mismatch is there in the left side of the slope. So in that case, the next step, from the crest point, okay, from the crest point from the crest point, we have to measure 10 millimeter below and 15 millimeter below the crest. Okay, so what you can do is, you can use 2 rulers, or you can borrow from your friends. Take 2 rulers. From the crest point, you go little 10 millimeter below and see how wider your nose bridge is, and then you go 15 millimeter below and you see the how wider the nose bridges are. Okay, I will show you now. Yes, madam. Ruler. Okay. 10 millimeter below the crest. Listen, please, listen. You can make 2 points 10 millimeter below that horizontal line, and another second point at the 15 millimeter below the horizontal line. Can you all make? Using a normal scale, you can make 10 millimeter point 10 millimeter below the horizontal line in the center of the line, and then you can make the second point 15 millimeter below the horizontal line. It's very easy, no? You can make 2 points very easily. And using the Fairbank ruler, you can measure how wider you want the distance between the rims. I have measured that it is 18 millimeter at the 10 millimeter below the distance between the rims, and then 15 millimeter we have 22. Okay, so I can mark 18 millimeter and 22 millimeter at the bottom. Using the rulers, nose bridge wide, how wider it is. That means from the crest point 10 millimeter below the crest point, how wider your nose bridge is, and 15 millimeter below the nose bridge, how wider your nose bridge is. Okay, so once you are done with those 2 points, you can actually measure using the Fairbank ruler, or if you are able to measure with the regular ruler, you can measure how wider your subject's nose is, 10 millimeter below the crest point and then 15 millimeter below the horizontal line. Okay, once you are make with that points, you can make a normal cut. Okay, so something like this. Are you able to follow? So once you are done with this cut, you can make sure and see. இன்னும் கொஞ்சம் clear focus பண்ணுங்க. And now you can see how perfectly it has fitted compared to the demo frame whichever we have used before. So like this you can also try. So once you are done with this, you can have any demo frames being given to you by the volunteers. Using that frame, make the outline. Okay, keeping that to the center of the nose bridge whichever we have made for that particular subject. Okay, remove the demo lenses out of the demo frames, and then keeping this at the center, you can make the outline of the demo frame, and then you can make the model frame for the subject. Are you all very clear? You can try. Okay. Demo frame been given to them. Yes. Yes. But provided that the frame model should be there with the manufacturer whichever you are going to give. நீங்க ஆர்டர் பண்ற manufacturer கிட்ட அந்த மாடல் டை இருக்கணும், அந்த மாடல். பட் இப்போ இந்தியாவுக்கு இது புதுசு, but it's been there for a long time in the other developed countries. using the demo frame given to you on your table, kept on your table, you can make an outline of the frame like this. So once you are done with the outline of the demo frame, next step is very easy. You have to cut the remaining part and make the spectacle frame. Please maintain silence. Volunteers, please make sure that they are following it. Okay, so I am almost done. Okay, so you can see this is what is the final outcome. Being the shape taken from the demo frame, you can make the outline and you can cut the remaining part of the chart paper. So you can understand how the customization can be incorporated in terms of making the spectacle frames. Okay. Sorry. You can just hold and show them. Tight up on the tight. Okay. I know it's a little tough for you to understand, but this is how you have to get an idea that this is how things are being done. Okay. First bench done. Where is the frame? Where is the frame? This row. Pantingla. Me kursi ke paar. See, even in case if you are not able to do, no problem, because we are running short of time. So I can move on to show the demo of the crutch glasses. You can do it later on. Is that okay? Okay, fine. Christy, crutch glasses on the frame box. On the frame box, like crutch glasses. On the frame box, leather. வேற யார்கிட்டயும் போயிருக்கா பாருங்க. See, participants, in some of the demo frame, by mistake the crutch glasses also come. Please give it back. In one of the demo frame being given to you, there is one crutch glass. Yes. Okay, fine. See, once I am done with the demo, I am going to give it to you all. It will come by turn. Okay, so you can have an hands-on experience with the crutch glasses. So like I was mentioning in the presentation, there are two types of crutch glasses being followed in our regular practice. One is the fixed and the sturdy one, and the second one is the flexible nylon cord one. Okay, so the one which I bought for today is the flexible and the nylon cord one. Okay, so I can show you with the volunteer here. Sir, inga konjam focus pannu. Okay, so we assume that the patient is suffering from ptosis. You can close it voluntarily. Okay, don't open it. Okay, so we'll try and open with the crutches in place. Okay, so you can see, can you all see that crutch in place, the flexible and the nylon cord one? Can you all see in the projector screen? Therida sir? Okay, even if it is not visible, no problem, I will give it to you all in turns. Okay, so you can, sir, close up, konja close up kattunga. Sir, in the area. See, for the demo purpose, I have asked the volunteer to voluntarily close his eyes, and he is not going to open his eyes on his own. We will make the eyelids to open with the help of the crutch. Clear, sir? Okay, fine. So you have voluntarily closed your eyes, right? Okay, so and you are not going to open on your own. Is that okay? Fine, clear? Okay, fine. So first you have to identify the crease area, okay, and then you identify the position, and the length of the crutch can be identified using a piece of any thick paper. You can identify once you are selected with the frame. Okay, so the first step, you have to select the frame for making the crutch glasses, and then with the normal position, okay, of wearing the spectacle lenses and with all sort of adjustments, you have to measure how length you want the crutch, okay, because since it's a flexible one, we don't have that much trouble with the measurements. But if you are going to make a fixed and metal crutch glasses, that is where these measurements will be very, very crucial. So from the back of the superior rim of the spectacle lenses, you have to measure in what length you want the in what length you want the crutch to be placed. Okay, so say it will be somewhere around it can somewhere around 10 millimeter or 15 millimeter or 13 millimeter or 14 millimeter. Okay, so accordingly you can tell the manufacturer to keep the length as 12 millimeter or whichever record for the patient. Okay, and you are not going to open your eyes on your own. Okay, look, keep your head straight, position the crust, and then okay, so now you can see you are not voluntarily opening, right? Okay, look straight. See, he is not voluntarily open his eyelids. It is held open only with the help of the crutch in place. Okay, so once you make the patient to wear the crutch glasses, ask the patient to have a little bit of blink. So blink panna mudiyadappa, blink panni paru. See, with the crutch in place, since he is a normal patient, he is able to blink. Okay, so some of the patients, it should not, when the crutch taking in place, it should not hinder the normal lid closure position. Okay, so make sure that the patient will be able to close their eyes like habitually. Okay, close panni open pannunga, close panni open pannunga. Okay, fine. Neenga open pannavana, neenga close pannunga appo. Okay. So during the normal in-house training, ask the patient to wear it for 20 minutes and ask them to wear in front of you and move around with the crutch in place, and then they can let us know in another 20 minutes time or have another 30 minutes time. They can let us know that if they feel any tenderness or any pain in the position where the crutch is going to be in contact. So in that case, we may think of having some adjustments with the crutches. Okay, fine. So are you all clear? Okay, so I will make this to go around the tables so that you can have the hands on wrist. You can try and make your friends to wear it so that you can feel that experience, how they are going. Okay, fine. சரி, இதை க்ளோஸாக காட்ட முடியுமா? Please don't worry, even if you are not able to see it clearly. Okay, once we are done with the live demo, I can keep it aside, or I can even give it to the volunteers. You can just have a look at closer, and then you can give it back. Okay, so this is basically a Fresnel press-on prism. It is mentioned as, it usually comes in the box like this with the prism strength mentioned on the top, and they will also mention the base, because once you take out from the box, it only with the experience you will be able to make out the prism base. Otherwise it will be in a initial as a beginner it will be very tough for you to determine the direction of the base. So in that case, while removing the box itself, you have to be very specific in which direction the base is mentioned. Okay. Demo போட்டுருப்பா. Can I have one more demo frame? The other one, other than the crutch. Any other demo frame is there? So, this is, see, you can see how flexible it is. You can see, can you all see it? How flexible it is. On one side I can feel, you don't have to feel, but it will be very, very smooth and polished. So that is the portion where we are going to get pasted over the spectacle lens. Okay, and the next, the other side of the frenal prism, you can feel those ridges. Okay, you can feel it just by placing your fingers. So that is where the frenal prisms are being manufactured. Okay, so you have to determine in what base. So now it is based down here. Okay, I can see the base mentioned here, so it is based down. So suppose if you want the base out to be placed over the spectacle lenses, for the right eye you can position like this. Okay, so for the right eye you can position like this. Okay, can you all see? It's a demo lens. Okay, I have just kept it over the lens surface. It has the tendency to get pasted very easily. Okay, so with the application of water or any normal distilled water, you can keep you can paste it very firmly. So the next step, once we determined, okay, so I have kept it as base out now. Okay, so once you have determined the base direction, you have to position like this and make the outline of the spectacle rim. Okay, just remove the spectacle rim. So I have removed the spectacle rim, keep it against the frenal prism. Okay, so what I am going to do now is going to cut the frenal prisms. No, clear therida? Okay. Okay, so once you cut like this, you can remove that, apply a bit of water, you can just splash it. Make sure that there is no air bubble get trapped between the lenses, demo lenses and the spectacle lenses and the prism. So that it is done now. Okay, I can give it to you over to the tables. You can circulate among yourself and have a look. Oh, it's almost done. Okay. So in case if you want a sectoral one, accordingly you can make a cut as per the need of the patients, and then you can place it as a section either at the top of the rim or at the bottom. Crutch, front row crutch classes. Where is the crutch? It is still there in the second table, so you have to move it fast. First table, crutch classes, you are done with the crutch. Second table, quickly have a look and then pass it over to the next table. Volunteer, I think the volunteers can help. Otherwise, they will take more time. Just give them 10 seconds or 20 seconds, and then it can be moved over to the next table. Any doubts? We are almost done. Any doubts you have? Second table, your third table, you are done with the crutch. Frontal prisms. See, maybe the frontal prism you can move it from the last. This table, crutch glasses, no?
ரெடியா? சூர்யா அதை இங்கே வச்சுருங்க, எனக்கு எடுத்துக்க கஷ்டமாக இருக்கும். தேங்க்யூ. Ready? Okay. So I'll be telling few steps in making a prosthesis. The first few steps is what I'm going to make. Second few steps you're going to make. Okay. So majorly you will cover the painting portion of a scleral prosthesis. Unga kaiyila irukradhu whatever you have is a dummy shell which we call as a scleral prosthesis. Okay. So it has two components, the black center circle that is called a disc button. Okay. The white area which is called the PMMA. So the prosthesis is primarily made of PMMA. Okay. Polymethyl methacrylate. So that is what you have in your hand. That is the real shell which we dispense. That is the material that we use to dispense the patient's prosthesis. Okay. So now what I have in my hand, can you all see? Can you all see? Yeah. So this is called an silicone mold. Okay. So this is used in patient where there is no eyelids. So we use them to stick on either over the glasses like this, or we paste it if the socket is concave. Now today we are going to make a dummy shell of this silicone prosthesis. So இப்போ நான் இதை வந்து என்ன சொல்ல போறேன்னா anophthalmic socket னு இதை சொல்ல போறேன். Okay. ஏன் இது anophthalmic socket னு சொல்றேன்? Can you see cornea, sclera, anything inside of this? Yes or no? Okay. So இது ஒரு empty space. Okay. So any eye without any ocular structure is called an anophthalmia. Correct? அதுதானே பார்த்தோம் morning. So in the empty shell, in the empty socket we are going to make a customized prosthetic eye today. Okay. So any prosthesis la first step நம்ம இன்னைக்கு அந்த வீடியோல என்ன பார்த்தோம்? யாருக்காவது தெரியுமா? You had a short video played. Anybody know the name of the first step in making a prosthesis? Okay, அது பேர் வந்து alginate impression. நம்ம எல்லாமே இப்போ யூடியூப் வீடியோஸில் பார்க்குறோம் இல்லையா, கையோட காஸ்ட் எடுக்கிறது, பேபிஸோட காஸ்ட் எடுக்கிறது. ஸோ இது எல்லாமே பண்ணுறது இந்த alginate மெட்டீரியலில் தான். ஓகே. ஸோ we call them an alginate. ஸோ இப்போ நான் ஒரு alginate impression எடுக்க போகிறேன். ஓகே. Now whatever you call this is called an impression tray. Idla various holes irukku, correct? That hole is used to replace. Now if you see, it has a small curve here. Innu konja zoom panikonga. You see a small curve that determines whether it is a right eye or a left eye. Ipo I want to take an impression of a right eye. Appadina na indha curve enoda right eye ku straight ah vechu paakanum. This curve should match my nasal bridge. Okay. Now in case if I want a left eye, adukana impression cast na edukanum. So now the nasal bridge is towards my left ones. I will pass on few conformers to find out which is right and left for your understanding. So idha impression tray நம்ம சொல்லுவோம். There is a center hole along with the major holes. இது எதுக்காகனா alginate pass ஆகிறதுக்காக. Now since I know the socket is very small, இவ்வளோ பெரிய impression tray உள்ள போகுமா? போகாது. ஸோ இப்போ உங்ககிட்ட இருக்குது இல்லையா, why I chose that size is, that is the minimum size a prosthesis can be, which is approximately 14 mm. ஓகே. ஸோ நான் ஒரு 14 mm impression tray-வை இந்த சாக்கெட்குள்ளே இன்சர்ட் பண்ணுறேன். ஸோ கேன் யூ see? பார்க்க முடியுதா? ஸோ I have inserted. This is fitting well. கரெக்டா? ஸோ இதுதான் ஒரு ப்ராப்பர் இம்ப்ரெஷன் காஸ்ட். ஓகே. ஸோ இப்போ இது வழியாக தான் நான் வந்து அந்த ஆல்ஜினேட்டை பாஸ் பண்ண போகிறேன். பீப்புள் ஃபோக்கஸ் ஆகுமா? I have prepared the alginate solution and I'm just going to gently press here. Because of the AC, it has dried. So I have just filled the socket. Now this is going to be a little dirty always. So now we leave it for around 3 minutes to settle. Okay. So now I am going to touch and feel it to know whether it has set or not. You see now it is not watery anymore. So I am going to gently pull the lids and take out the impression. So now there are few remnants. So even in a real anophthalmic eye there will be some remnants of impression. It is important to clean this. Now I have a detailed impression of this socket. If you can see, can you see the back surface of the socket is well placed here. So the next step is we are going to make a wax out of it, wax pattern out of it. That is used for trial of the patient. இப்போ நம்ம இத நிறைய வாட்டி ட்ரையல் பண்ண முடியாது, கரெக்ட்டா? So we have to do something where centration வைக்கணும். We have to determine the corneal size. So for that we are going to make a wax mold of it. So I have just immersed the impression in an alginate cup. So this will settle. Okay. So in the meantime, we'll explore how a iris painting is made. Unga ellar kailiyum on the scleral shell irukilla. What you have to do is, you will have a stick like this. Take out that stick and you can choose any side. Whichever you see a lot of superior side, just sky paatha madri இப்படி stick பண்ணிக்கோங்க. Can you understand? Just stick your eyes on top of it. Don't use your nails over the clay area. Surya, AC கம்மி பண்ண முடியாதா? வேணுமா? Off பண்ணியா சார்? It's taking very long. With the iris painting now. So you all have given a black pigment. you want to use your own iris, you can use. Okay. color or not. உங்ககிட்ட ஒரு அந்த thick solution இருக்கு இல்லையா, அந்த thick solution இந்த eyes மேலே இப்படி அப்ளை பண்ணால் உங்களுக்கே தெரியும். Can you see? Not the watery solution, thick solution மேலே அப்ளை பண்ணால் you will know you have achieved your color right or not. Done? Iris முடிஞ்சுதா? Yes, no? I'll give you only 3 more minutes for the iris to be done. இன்னொரு 3 minutesல iris முடிச்சிருங்க. Simultaneously இவங்க பெயிண்ட் பண்ணியிருக்கிறதும் ஃபோக்கஸ் பண்ணுங்க so that I can see. இதை எடுத்துக்கோங்க ஒரே நிமிஷம். Dana?
சவுண்ட் இல்லாமல்
ஆ ஓகே. எதுப்பா இது? Okay guys, done? Okay guys, we are done. Iris timing முடிஞ்சது. யாரெல்லாம் இன்னும் முடிக்கல? Done guys? So we'll give a quick recap. First நம்ம பார்த்தது வந்து impression, correctா? So we took an alginate impression, then we did an iris painting. Okay, in the meantime iris painting time குள்ள நம்ம பண்ணது என்னன்னா wax molding னு சொல்லுவோம் அந்த ஸ்டெப் பேர். Okay, so now this was my impression cast. இதுதான் எனக்கு கிடைச்ச impression, correctா? So இந்த impression ஓட wax carving I have done. Can you see? So now the socket is filled properly. Okay, now இப்போ இதுக்கு என்ன வேணும்? What structure we have to give to this cornea and iris, correct? So now how do I determine the corneal size? By first marking the pupil. Okay, so in a real patient நம்ம எப்படி மார்க் பண்ணுவோம்னா the same pupillary center. ஓகே, ஸோ இப்போ ஆனோப்தல்மிக் சாக்கெட்டில் பியூபிலரி சென்டர் எப்படி கண்டுபிடிப்போம்? கண்டுபிடிக்க முடியுமா? முடியாது. இட்ஸ் அன் ஒப்பாக் ஸ்ட்ரக்சர், கரெக்டாக? ஸோ யூ டேக் த கான்ட்ராலேட்டர் ஐயோட pupillary mark to the nasal bridge center. So whatever is the IPD, interpupillary distance, இப்போ ரைட் ஐயோட IPD 30 mm இருந்ததுன்னா the same center to 30 mmல நான் இந்த வேக்ஸில் ஒரு சென்டர் பண்ணிப்பேன். Now what if the patient is bilaterally blind? ரெண்டு கண்ணிலையும் அனாப்தல்மியா இருக்குது. அப்போ நான் எப்படி சென்ட்ரேஷன் மார்க் பண்ணுவேன்? Now this eye especially, now this is a model eye, correctா? இப்போ இதுக்கு I cannot mark a center with an IPD. So what do I do is, ஜென்ரலாக நம்ம எல்லாருக்கும் pupillary center எங்கே இருக்கும் அப்படின்னா exactly at the center of our eyelids. So I am just going to mark a center of an eyelid mark. So now this is my nasal bridge curve. This gives me the exact center, correct? So how do I mark the center? And then I just insert a stick. So ideally this is my center. Okay, so now I'm going to make a cornea. Okay, ஸோ சேம் கார்னியாங்கிறது எப்படி மேட்ச் பண்ணுவோன்னா இப்போ பேஷண்ட்டோட அதர் ஐயோட ஹரிசான்டல் விசிபிள் ஐரிஸ் டயாமீட்டர் HVID நம்ம காமனாக சொல்லுவோம். HVID 11 mm இருந்ததுன்னா we are going to make a 11 mm circle or tentatively match the other eye's corneal size. Okay. Now this is a very small eye. As I said, இதோட total ஐயோட length 14 mm. So approximately எவ்வளோ mm ஒரு cornea இருக்கும்? In a just born baby eye, how much is the HVID? So now after making a cornea, we have to insert and look for any squint or a ptosis. Okay. So now how do I determine it? Can you see? Center ka. So this is how a cornea is done. Now approximately when we see the eye is very smaller, if you keep a larger cornea, avangaloda sclera-ve theriyama irukum. Okay, so according to the size or the HPF of the eye, HVID differs. Like I said, ipo contracted socket irukku. Ipo or normal eye 34 mm irukku appadina contracted eye 20 mm da irukum. Anga you cannot give a 11 mm iris. You have to give a shorter iris for you to look at the sclera very well. Okay, so this is how we determine the wax molding. So idha vechu we are going to start making an eye. Okay, so idha vechu panna eye da unga kaiyila ellarkittiyume irukku. So now idoda next step enna mold making. So ipo idoda oru cast venum illaya namakku. So that is how we have made this cast here. Now this is made up of dental stone. Okay, unga ellarku theriyudha. Now we insert this iris button. Can you see here? This is called an iris button. We insert the iris button. We actually trim this. Ipo ungalku theriyunundradhukaga I have kept a larger button. So now this is trimmed to, this is approximately 13 mm. So in the button oda size vandu 13 mm. So we have cut down it to 10 mm and we have given you. Okay, so in the 10 mm button is kept inside the, ipo idla oru chinna circle theriyudha ungalku, a small depth. Can you see here? A button is fitted there and a polymer resin. Morning video la paathom illaya, it is a liquid resin. So it will be in a powder form. You mix it with a solution and then put it, heat it. So now once the mold is made and then ida close panni, we keep it in the machine for polymerization. Polymerization engiradhu periya vaartha onnu illa, we are just baking it, pressure cook pandrom. Okay, once we pressure cook it, all you will have is a combination of button and a white PMMA. Okay, now this will be rough. So as you saw in the video, we will have to trim and polish it in the machine and then have a trial on the patient. Okay va? So ipo idha trial paakalama. Now can you see? So now this is the trial of a prosthetic eye. So this is the first trial nu solluvom. With the combination of iris and the white PMMA, this is the first trial which you saw in the video. Okay, now once my fitting is done, enak endha scleral show illa, there is no squint, all the fit is matching now. So the next step is I'll take this for painting. Okay, so scleral painting step by step நான் காட்டுறேன், அதை நீங்கள் அப்படியே ஃபாலோ பண்ணிக்கோங்க. ஸோ நம்ம எல்லாருக்கும் ஒயிட் ஸ்க்ளீரா, ஒயிட் ஐஸ் இதெல்லாம் தான் தெரியும். பட் மினிமம் உங்ககிட்ட இருக்கிற எவ்வளோ கலர்ஸ் கொடுத்துருக்காங்க? என்னென்ன கலர்ஸ் இருக்காங்க? How many colors? Just number மட்டும் சொல்லுங்கள். 5 colors. So primarily அவ்வளோ கலர்ஸ் இருக்குது ஸ்க்லீரால. Okay, even a white eye will have at least these 5 colors in the eye. Okay, so blood vessels you can actually draw with red lines. Okay, but I have also given a thread. If you want to explore, you can use those threads. And the thread எதுக்காக யூஸ் பண்ணுவாங்க தெரியுமா? மார்னிங் வீடியோவில் நல்லா பார்த்தவங்களுக்கு தெரியும். That is why I have zoomed that procedure. Scleral painting அப்போ அந்த த்ரெட்டில் அவங்க என்ன பண்ணாங்க? Would anybody like to say? வீடியோ பார்த்தீங்களா? வீடியோ ப்ளே பண்ண முடியுமா? ப்ரெசன்டேஷனில் இருந்த வீடியோ. அது வரைக்கும் யாருமே கெஸ் பண்ணலையா? வாட் இஸ் த யூஸ் ஆஃப் தட் த்ரெட்? Yes, actually we predominantly use those thread for blood vessels mainly, and certain people use it as a signature. Okay, so mostly any anaplastologist or an ocularist, they use to make their signature. So we'll have a quick recap on whatever the steps we have done. Rotate பண்ணிக்கணும்டா. Escape கொடுத்துட்டு வீடியோ rotate பண்ணுங்க. பான் யாருக்கெல்லாம் சொல்யூஷன் வேணுமோ பாஸ் பண்ணுங்கள்.
சொல்யூஷன் இல்லாத பர்சன்ஸ்க்கு தான்.
ஆமாம்,
இது
ரெண்டு both. So can you see? So this is the steps which we done. See how the wax molding was done. So this is how a mold is made. The button has already been pinned. Pause பண்றீங்களா? Okay. Later. இல்லை நான் அப்புறம் ஃபார்வர்ட் ஓகே. forward
Big screen.
Big screen. So everybody's attention please. So we'll continue once with the video, then we'll do a scleral painting. அது அப்படி ப்ளே பண்ணிடுங்களா, ப்ளே ஆகும். So now this is how trimming and polishing is done. So if you see this step, once the painting is done, again they are keeping it for polymerization. Okay? Okay, Ananda. Live streaming கொடுங்க. வீடியோ ஆஃப் பண்ணிடலாம். Okay, if you want to have a better outlook on how a scleral painting is done, இப்போ நீங்க என்ன பார்க்கணும்? Those I am just going to paint a darker eye so that you know how many structures or how many colors are minimally used in making an iris or a scleral painting. Now I want a two color, so I am using a combination by mixing blue and yellow. What do I get? யாராவது color theory தெரியுமா? முடிஞ்சிருச்சு அவ்வளோதான். And how long ever they take to paint the sclera அவ்வளோதான். If you want to know what color I have done, you can just see. Why have I given a green color? யாராச்சும் green color sclera-ல பார்த்துருக்கீங்களா? So every pigmented eye will have a green color. Okay, every pigmented eye. I cannot give a direct red. Okay, so on a white, if I give a red directly, it will become very bright red like a cornea. So அந்த ஒரு மண்ணு shade வரணும்னா I have to first give a green shade. So in every sclera we start with plain blue, and every dark shade we start with green color. Okay, now the technique we use is called a layered painting. அதாவது லேயர் பை லேயராக தான், டைரெக்டாக ஒரே ஷேட் நம்ம கொடுக்க மாட்டோம். டு ஜஸ்ட் டிஃபைன் ஈச் லேயர் லைக் கன்ஜங்டிவா, கார்னியா, ஸ்க்லீரா, அது மாதிரி. If you look keenly, I am drawing blood vessels with paint, not with a thread, just to say that at certain times we can always do that when you have a look like scleritis or episcleritis, or even a very minimal blood vessels like telangiectasia, you can draw it with a thread. இதை நல்லா ஜூம் பண்ணுறீங்களா? அவ்வளோதான் ஜூம் ஆகுதா? ஓகே, நோ ப்ராப்ளம், I'll pass it. அவங்களோட ஒர்க் ஃபோக்கஸ் பண்ணுங்க. இது அப்படியே பாஸ் ஆன் பண்ணிடுங்க. ask them not to touch there.
இது ட்ரை பண்ணணுமா ஏதாவது?
அதுவே அவங்க பாஸ் ஆகி வரத்துக்குள்ள ட்ரை ஆகிடும். have any questions, simultaneously you can put up because we are running out of time. One, idiom pass பண்ணிக்கோங்க. இதை பிக் எடுக்கணும்னா கீழே தனியாக எடுத்துகிட்டு வச்சு தான் எடுக்கணும், அப்படி எடுக்க முடியாது. ஆ okay, shall I come around and see? முடிச்சிட்டிங்களா? டன். ட்ரை பண்ணுங்க. நோ ராங் இன் இட். எதாவது ஹெல்ப் வேணுமா? ஐரிஸ் பிளெயினாக இருக்குல்ல, டார்க் கலர்ஸ் ஆட் பண்ணலாமா? ட்ரை பண்ணுங்க. Generally give color evaporate ஆயிடுச்சு. First dark color,
ஃபுல்லாகவே ப்ரௌன் கொடுத்துருங்க.
ஆமாம், ஃபர்ஸ்ட் டார்க் கலர் கொடுத்த பிறகு தான் மேலே யூ சி சம் ஷேட் ஆஃப் ரெட்னஸ் இருக்குது. இதுக்கப்புறம் ஐ கேன் யூஸ் அ can you see? Yes. Actually இது காயல, இது பெட்டராக காஞ்சதுன்னா you will see the stroke separately. உங்கள் கலர் actually evaporate ஆயிடுச்சு. This mineral color is okay. Done? So இன்னும் கலர் இருக்கு, you can choose colors, no? There's still some amount of solution left. You want to try? First, whatever, fill it with dark colors. Let this dry for a while. அதுக்கு மேலே black strokes. அவ்வளோதான். Done? பார்க்கலாமா ஐஸா? ஐஸ் கேட்குறாங்க. நீங்கள் ஆசையாக ஃபோட்டோ எடுத்தது போதும், நான் ஆசையாக பார்க்க வந்திருக்கேன். The cornea is good. Done? உங்கள் ஐஸ் எங்க? பாய்ஸ் கேங்கோட ஐஸ்
அவங்க உங்களுக்கு தரல, ஸோ நாங்களே இதை மேக் பண்ணியிருக்கோம்.
ஏன்னா ஷெல் இல்லையா உங்களுக்கு?
இல்லை, இது நாங்கள் டிஷ்யூ பேப்பர் வச்சு மேக் பண்ணியிருக்கோம்.
ஏன் ஷெல் கொடுக்கல?
அவங்க பண்ணிட்டு இருக்காங்க.
ஓ, நைஸ் இனோவேஷன். காட்டுங்கப்பா பார்க்கலாம். நைஸ், குட் ஐரிஸ், ஸ்க்ளீரல் பெயிண்டிங். வெறும் ஒயிட் கலர் மட்டும் பிடிச்சிட்டிங்களா?
சொல்யூஷன் காஞ்சி.
வெரி நைஸ். ஸோ ரெட் வெசல்ஸ் பெயிண்ட் பண்ணிங்களா? அழகாக பண்ணியிருக்கீங்களே. வெரி நைஸ். கார்னியா சூப்பர். ஒன் இம்ப்ரெசிவ் கார்னியா சோஃபார். வேறு யாராவது இம்ப்ரெஸ் பண்ணுறீங்களா பார்க்கலாம்? யார் நல்லா இது வந்து ஒத்த கண்ணு சிவராசன் தெரியுமா, அந்த மாதிரி இருக்குது. ஏன் கார்னியா விட்டுட்டீங்க, நிறைய சொல்யூஷன் வச்சுருக்கீங்களே. கார்னியா ட்ரை பண்ணலாமா? இந்த ஒன்றே போதும்யா. இது என்ன தண்ணியா? சரி, இங்கே எதாவது சொல்யூஷன் எடுத்துட்டாங்களா? எப்பயோ ஏசி ஆஃப் பண்ண சொல்லிட்டேன், எவாபரேட்டே ஆயிடுச்சு. நான் லாஸ்ட்டில் போயிட்டு வரேன், அதுக்குள்ளே டெலிவரியாக செய்வேன். அங்கே டேபிளில் ஒரு 2 பாட்டில் இருக்கும், அந்த பாட்டில் எடுத்துகிட்டு வந்து உங்கள் ஸ்டேஷனில் வைங்க. வில் ஃபினிஷ் அ கார்னியா. 2 glass bottles. ஏன் அங்கே லைவ் ஸ்ட்ரீமிங்கே போகல, உங்களை யாருமே பார்க்கல, நீங்கள் தான் போய் எடுத்துகிட்டு வாங்க. தென் ஐஸ் என்னாச்சு? ஓ, காட்டுங்க பார்க்கலாம். சும்மா நத்திங் டு ஜட்ஜ். பாருங்கள், மைக்கை கூட தள்ளிட்டேன். இந்த பக்கம் ஒரு ஒத்த கண்ணு சிவராசன். எல்லாருக்கும் பிளட் வெசல் தான் நல்லா பிடிச்சிருக்கு போல. கார்னியா வரலையா? சொல்யூஷன் இருக்கா இல்லையா? இவங்க எல்லாம் எடுத்துகிட்டு வர சொல்லியிருக்கேன். அவங்ககிட்டேருந்து வாங்கி கார்னியா மட்டும் பெயிண்ட் பண்ணுங்கள். ஓகேயா, வைண்ட் அப் பண்ணலன்னா பண்ணலாம். சொல்யூஷன் நிறைய பேருக்கு
மாட்டேன் ம் அதான் பார்க்கலாம் அதான் சரிங்க முடிச்சுட்டு கூப்பிட்றேன்
Thank you, Rishi, for this wonderful video. Learning becomes even more meaningful when accompanied by a healthy competition. As a part of V-Opto 2026, students enthusiastically participated in various competitions that reflect their knowledge, creativity, and awareness. We shall now proceed with the prize distribution ceremony. May I request our respected dignitaries to kindly present the trophies, prizes, and certificates to the awardees. We begin with the e-quiz competition, which features enthusiastic participation and immersive display of knowledge and teamwork. The runners of the e-quiz competition are We begin with the e-quiz competition, which witnessed enthusiastic participation and an impressive display of knowledge and teamwork. The runner of the e-quiz competition are Arshavardhini, Keisha, Tejasri from School of Applied Science, Karaikal. Students are asked to come on the stage. The winner of e-quiz competition are Deepa S, Latifa K, Sujita A from Regional Institute of Ophthalmology and Government Ophthalmic Hospital, Chennai. Now we move on to the e-poster competition, where participation showcased creativity, innovation and scientific understanding through their poster presentation. The runner-up award goes to Priyadashni A, Rebecca M, Jonathan Philip from Sri Ramachandra Institute Higher Education and Research. The winners of e-poster competition are Gautam SP from School of Applied Science, Salem, Rajan R from School of Applied Science, Puducherry, M. Vishwa from School of Applied Science, Chennai.
competition on the theme of ocular trauma, causes, prevention and immediate action. In recognition of their creativity and commitment to promoting eye health awareness, we invite the following students to receive their prize of recognition along with a certificate. Ms. Jerusha M. Optometry, second year. Mr. Rehabilitate, V-Optometry, first year, School of Applied Science, Salem. Mr. Bryce Samuel, BSc Cardiac Technology, third year, School of Applied Science, Chennai. They gracefully accepted our invitation and supported us with their enthusiastic participation. Your presence has truly added great value to this event and contributed immensely to its success. As a token of our appreciation, we request a representative from each institution kindly come forward and receive the memento. Hindustan College of Health Science, Coimbatore. Kindly someone come from the institute and receive the memento. Hindu Mission Hospital, Chennai. Sri Ramachandra Institute of Higher Education and Research, Chennai. enthusiasm, creativity, and active involvement. Participants of the e-book and e-book competitions are informed that their e-certificates will be shared shortly.
Thank you, sir.
Thank you, sir. Gratitude is the foundation of every successful event. To propose the vote of thanks, I now invite Ms. N. Banu, Head of the Department of Optometry, Accuracy Coordinator, School of Allied Health Sciences, VMRF DUs, Chennai campus.
Respected dignitaries, distinguished resource person, respected deans, sir, faculty members, students and dear participants. Good evening to one and all gathered here. It is my honor and privilege to propose the vote of thanks on behalf of Department of Optometry, School of Allied Health Sciences, Vinayaka Missions Chennai campus, VMRF DU, at the successful completion of V-Opto workshop 2026. I express my deepest gratitude to our respected Dean, Professor Dr. B. Sendilkumar sir, whose visionary leadership and unwavering commitment to academic excellence continue to inspire us every day. V-Opto 2026 stands as a testament to your vision of fostering innovation, clinical excellence and lifelong learning among future eye care professionals. Your constant encouragement and support have transformed this workshop into a meaningful platform for knowledge sharing, skill development and professional growth. We are truly grateful for your guidance and for believing in the potential of every student and faculty member. Thank you, sir. I extend my heartfelt gratitude to Professor Amachudar ma'am, Admin in Charge, School of Allied Health Sciences, VMRF DU, HOD Optometry, Salem, for her continuous encouragement and invaluable guidance. Your support has always been a source of motivation in organizing academic programs that enrich the knowledge and clinical skills of our students and professionals. Thank you, ma'am. I sincerely thank Mr. Muthraj sir, Director in Charge, School of Allied Health Sciences, Chennai campus, for his constant support, encouragement and guidance throughout the planning and execution of this workshop. Thank you, sir. Our heartfelt appreciation goes to all our esteemed resource person, Mr. Satish Kumar sir, Senior Lecturer, Government Optometry College, REO GOH, and Mrs. Priya Balasubramanian ma'am, Founder, Iris Perfect, Maxillofacial and Ocular Prosthesis Clinic, Chennai, who generously shared their expertise, clinical experiences, and practical insights. Your engaging sessions, interactive discussions, and willingness to share knowledge have made this workshop a truly enriching learning experience for every participant. Thank you, sir. Thank you, ma'am. I would also like to extend my sincere thanks to all the faculty members, organizing committee members, coordinators, volunteers, administrative staffs, technical team and support staff whose dedication, teamwork and meticulous planning ensured the smooth, successful conduct of this workshop. Your efforts behind the scenes deserve our greatest appreciation. To all our participants and students, thank you for your enthusiastic participation, active involvement and eagerness to learn. Your curiosity, interaction and commitment made every session meaningful and successful. As we conclude V-Opto Workshop 2026, let us carry forward the knowledge, skills and inspiration gained. May this workshop serve as a stepping stone towards continuous professional growth, innovation and excellence in the field of optometry. Once again, I extend my heartfelt thanks to every individual who contributed directly or indirectly to the success of this workshop. Your presence, support and commitment have made V-Opto Workshop a memorable and meaningful event. Thank you all. Have a safe journey home and wonderful day ahead. Thank you.
Thank you, ma'am. As we conclude, we hope today's workshop has inspired each one of us to blend scientific knowledge, technical expertise, artistic precision, and compassionate care in our journey as eye care professionals. We extend our heartfelt gratitude to our respected dignitaries, esteemed resource persons, faculty members, delegates, participants, organizing committee, volunteers, and everyone whose support and dedication made V-Opto 2026 a grand success. We would to our official streaming partner, Shiva Pictures, for their excellent support in live streaming and capturing the memorable moments of V-Opto. We also request all our students and participants to support their work by subscribing the Shiva Pictures YouTube channel. I request everyone to stand up for national anthem.
Shubha